way late. We're going to go ahead and get started, everyone. If I can have commissioners take their seats.
Okay, Tony is not coming. She might come later today, but she's not making it this morning. Okay?
Thank you. Okay. Are we ready to go? We're ready? All right. Good morning, everyone, and welcome to this meeting of the Mental Health Services Oversight and Accountability Commission. My name is Mara Madrigal Weiss, and I am the chair of the commission. I want to thank you for attending today's meeting. Before we begin, I want to share with you that Jeff Margolis, our chief counsel, passed away on November 26th. Jeff was an important part of the commission's team. He was someone who cared deeply about mental health and wellness for all Californians. He had a long and distinguished career as an attorney and came to the commission from the Department of Insurance, where he served for many years. I would like to take a moment of silence to reflect on our friend and colleague, Jeff Margolis. Thank you, everyone. With that, let's go ahead and start today's meeting. The Commission's current strategic plan is committed to advancing the Commission's vision of well-being for all Californians. Cody, can you please bring up the strategic goals slide? Thank you, Cody. Now we will take roll and establish a quorum. Maureen, can you please take the roll?
Yes. Commissioner Bontrager. Commissioner Brown. Here. Commissioner Bunch. Here. Commissioner Carrillo. Commissioner Carnavale.
Here.
Commissioner Chambers.
Present.
Commissioner Chen.
Present.
Commissioner Cortese. Commissioner Danovich. Here. Commissioner Gordon.
Here.
Commissioner Mitchell.
Present.
Commissioner Robinson.
Present.
Commissioner Rolette. Here. Commissioner Tamplin. Vice Chair Alvarez.
Here.
Chair Madrigal Weiss.
Here.
All right. We have a quorum.
Thank you, Maureen. We will continue our effort to drive transformational change in February. The next commission meeting will take place on February 22nd in Napa. The meeting focus will be on strengthening early intervention to reduce criminal justice involvement and will include a panel discussion on best practices to strengthen early intervention and reduce criminal justice involvement and hospitalization for individuals with mental illness. The day before the commission meeting, on Wednesday the 21st, there will be a site visit for commissioners to tour the Napa State Hospital and talk with staff and patients about their experiences, which led to hospitalization and incarceration. Commissioners were presented with a site visit packet today, which provides more details. The information was also sent via email. I hope commissioners can join us in Napa. I know that we will have representatives from other state agencies as well as representatives from the legislature with us for the site visit. We also need to appoint a representative to the advisory board of the California Institute for Law, Neuroscience, and Education, part of the California Bench to School Initiative. This partnership between UCSF and UCLA aims to improve literacy outcomes in school settings by conducting interdisciplinary research on the intersection of science and society, focusing on neuroscience and socioeconomic factors. The advisory board will monitor progress and provide leadership. I would like to appoint Commissioner Steve Carnavale for this role, and I invite him to share thoughts on this opportunity. Commissioner Carnavale, please.
Thank you, Madam Chair. The institute, the new institute, was actually created also, UC Law School is part of that collaboration, which is what makes it particularly unique. Nowhere in the country are we bringing together neuroscience, education, and law together to try to make another effort to solve this so-called kindergarten to prison pipeline. And so we're focused specifically on the juvenile justice system and trying to bring new thinking about how we can stop that what seems like an inevitable problem. So I happen to be a co-founder of it. I helped lobby for the Institute, and I appreciate being appointed the Mental Health Commission representative.
Thank you, Commissioner Carnevale, and we look forward to hearing updates about this great work. Thank you. I also wanted to share some exciting news with everyone about our Empath project. Last year, the Commission dedicated $20 million from the Mental Health Wellness Act to expand the number of Empath units around the state. 11 units are currently being planned or built in various locations to serve individuals who are taken to the ER in response to a mental health crisis. Typically, people in mental health emergency wait many hours and sometimes days to get the help that they need. Empath units are built on the grounds of a hospital in close proximity to the emergency room and provide a more comfortable, quiet, and respectful experience for people needing mental health treatment and referral. We were informed this week that the states of South Carolina and Georgia have recognized the work of the Commission and want to expand this model and are now dedicating funds to build Empath units in their states. I share this because I think it connects well with the conversation we will have today on our strategic plan. The Commission is a catalyst for change, and if we provide leadership to solve some of our most pressing challenges, others may join us. In the case of Empath, the Commission has been working closely with Dr. Scott Zeller, who developed the model to help this innovative approach spread across California and now the nation. This is driving transformational change. I also wanted to highlight some of our youth advocacy efforts of the Commission. As you know, the Commission has awarded many grants to 20 youth-led organizations and 6 county offices of education who are now participating in a statewide effort to hear from youth and train youth advocacy approaches. In January and February, we're holding 4 convenings, which will include over 100 students who have indicated interest in participating in statewide efforts to speak about mental health planning related to schools and community services. The first meeting was held last Saturday at the Commission office in Sacramento. The next 3 convenings will be held on January 27th in Fresno, February 10th in Humboldt County, and February 24th in San Bernardino. Young people want to contribute, they want to help design the mental health system, and it is important that we create the space and the support to make that happen. We also have exciting news about the Children, Youth, and Behavioral Health Initiative, and I'd like to invite Vice Chair Alvarez to provide us with an update on the work being done to better serve our children and youth.
Thank you, Chair Madrigal-Weiss, and it's so great to see everyone in person. It's been a while, so Happy New Year. I'm happy to report that in December, the Governor's Office announced that the Department of Healthcare Services awarded $150 million to 262 organizations that support the mental health and wellness of our young people, children, youth, and young adults. The funding was announced as part of Governor Newsom's Master Plan for Kids' Mental Health. The Commission, in collaboration with the Department of Healthcare Services, administered round 4 of the CYBHI grant program, which awarded $50 million to 69 organizations in 30 California counties. These initiatives will launch youth-driven programs such as the All Cove Youth Drop-In Center model and other youth drop-in centers, but also models such as the Clubhouse model, Fostering Healthy Futures, Youth Peer Respite, and other youth-driven programs. Among the awardees are 4 existing All Cove programs and 6 new All Cove centers. And obviously, we're happy to see that these centers are being expanded in order to provide that integrated health, mental health, peer support, education support, and other services in one youth-designed location. These investments really reflect the work that we need to do in order to support youth mental health and respond to what young people are saying. The Governor's Office also announced $100 million to provide trauma-informed services to address the impact of trauma and support children and youth who are recovering from the effects of adverse childhood experiences. Additionally, the Commission is planning to administer round 5 of the CYBHI And these awards are going to be announced in the coming days. The round 5 of the CYBHI, to remind folks, is to support early intervention efforts, which are evidence-based or community-defined evidence practices. The RFA for round 5 was released on September 12th, and applications were received in early November. And again, as I mentioned, the evaluation of those applications is complete, and the awards will be announced soon. I want to take a moment and really connect these announcements with what this commission has been saying for a number of years that I've been a part of this commission, and that's the importance of partnership between the efforts of the commission and the work of the department, so that we all move forward as one united team to support the mental health of Californians. These awards are going to provide much-needed services and supports to children, youth, and their families, but they're also transforming our mental health system by lifting up the voice of young people who are proven to help drive the change needed to make our system more relevant to young people from diverse backgrounds. So huge kudos to the team for the continued youth engagement efforts, these opportunities to engage youth from across the state and really take this work into that next level. I'm particularly proud of that strong collaboration that's taken place between the Commission and the Department of Healthcare Services, and looking forward to what's to come. Thank you.
Thank you, Vice Chair Alvarez. We will now hear an exciting update on new staff joining the commission. I'd like to welcome our Administration Chief, Lauren Quintero. Please go ahead, Lauren.
All right, sorry, they had to unmute me. So we have hired Kelsey Wood. Kelsey Wood brings her expertise to the Commission's Human Resources Department as our newly appointed Associate Governmental Program Analyst and Training Officer. After a decade in sales and recruiting positions within the private sector, Kelsey is returning to state service. A proud Sacramento native, she earned her business degree with a concentration in human resources from Sacramento State, and she previously served as a seasonal clerk at CalPERS in their Human Resources Department. Residing in Sacramento with her husband and two young children, Meyer and Lillian, Kelsey is not only a seasoned professional, but also a devoted family person. Beyond her professional commitments, you'll find her passionately cheering for the San Francisco 49ers and the Sacramento Kings, exploring local eateries, and learning to sew in her leisure time. So we're really excited that Kelsey has joined us.
Thank you, Lauren. Welcome, Kelsey, another 49ers fan. So happy to have you and look forward to meeting you in person. And at this time, I am very happy to announce that we have former Commissioner Katera here in the room with us. Commissioner Katera Tamplin is here to be recognized for her many years of service to the Commission and to the people of the state of California. Katera's contributions to the Commission span more than a decade. She was appointed by Governor Jerry Brown in 2013 and served for 10 years, including serving as Vice Chair in 2018 and leading the Commission as Chair in 2019. When I hear mental health consumer advocate, I think of Katera. While serving as Commissioner, she also served as Chair of the Commission's Client and Family Leadership Committee from 2016 to 2023. She is a champion for mental health consumer rights and led the Commission's support for and passage of Senate Bill 803, which brought peer certification to California. She led the way on legislation to remove stigmatizing language from state statutes, which elevates the importance of reducing stigma at all levels of state government. She worked with SAMHSA to create national standards for peer support certification. She also represented the Commission before state legislature policy committees, providing testimony on the importance of peers in the policymaking process. Katera was the longest-serving commissioner in the history of California's Mental Health Commission, and she has represented the Commission so well with a perfect combination of fierce determination and genuine compassion. Katera, we would like to present you with a resolution to honor your many years of service to the Commission. But before we do, I want to invite commissioners to say a few words about her many contributions.
I don't want to go first, but I'm one of the newer standing commissioners, but I want to give respect to anyone that wants to go first. I can go.
Please,
You can go.
Commissioner Chambers.
I just want to highlight Commissioner Tamplin's unapologetic belief that recovery is possible, and that with the standard of imperfection but excellence, striving for excellence, will really lead this movement to the next level. And she's instilled that in me as a young leader, as a woman of color, to rise against any adversity and to keep my eye on the goal. I believe that the standard that Commissioner Tamplin has set for excellence here on the commission will last for, I think until it ends, and hopefully it never ends, but you've left a legacy and a mark that I have, a pathway for me to follow as a young leader, as a businesswoman, and a fierce advocate for Californians around mental health in our state. So I just want to acknowledge the work that you've done, the seeds that you planted in my life and other young leaders, and just value the work. I hope that you never go away, but at the federal level, I really hope that you will continue to uplift California and the needs of California, and then also, shine a light on the work and the innovative practices that we're doing. And I hope to be a partner with you to represent our great state at the federal level. And I look forward to the new work that we have to do across the nation and representing our state. So I appreciate you, and you're one of the most excellent women, mothers, advocates. I have such a excited future with you as my mentor, friend, and colleague. Bless you.
Commissioner, I'll just say ditto, so.
Yes, please, Commissioner Brown.
Let me just say a few comments here. First of all, to those watching from the outside, the commission is a very diverse group of people. We come from all walks of life and very different backgrounds. And we develop a tremendous camaraderie. It's been one of the highlights of my career to be involved in this organization. And I think the diversity that we have on this panel, the diversity of experience, the diversity of color, the diversity in so many different ways is what makes it a strong commission. And we have a lot of work to do, but we also have a lot of fun together as well. And I think our fun factor got reduced a little bit with you leaving the commission. And I just want you to know that it's going to be a little less bright, a little less bubbly, a little less fun to do this. And I just want you to know that you have a tremendous amount of respect from all of us for what you've overcome, difficulties in your life that brought you here, and the fact that you have become a wonderful role model and mentor for people with lived experience, that you have a passion and a drive in your heart that is amazing, and you're just a class act, and we just want to let you know that we're going to miss you.
Ditto. Double ditto.
We have the privilege of intersecting in a lot of committees and meetings. And I just want to add, in addition to the quadruple ditto, you are one of the most hopeful people I've ever met. You are very hopeful. And you have an optimism that radiates in a room when you speak, even when you disagree. And I like that. I like hopeful people who can disagree respectfully and still radiate optimism. So quadruple dittos to you.
Okay, I'll say I don't even know. Okay. Katera, I completely agree with everything that's been said. I also just want to add, You're also incredibly patient for those of us that do not have the extensive history and background in mental health and all of the work that you've done. And to be able to walk folks through this learning journey is part of our collective work to be better, to be more responsive to the needs of our communities. And I have benefited directly from that teaching and that inspiration. And I feel I'm a better advocate, I'm a better colleague, I'm a better mom because of that inspiration and teaching. And I'm so, so grateful to that. And I'm really excited that you're working at the federal level, because you're not only bringing the perspective of the state, you're bringing personal lived experience, you're bringing these perspectives that our many times our federal government does not have. And that is incredibly powerful and incredibly hopeful, to Commissioner Rollette's comments, for what can come in the future. So congratulations and thank you for everything.
All right, and I don't know, so we have Commissioner Gordon online, who would also like to make a comment, please.
Yes, just very briefly, Katara, I learned so much from you on the commission, and I just wanted to say thanks and so appreciate getting to know you and work with you, and all the best at the federal level. We hope we'll work with you for many years to come, and all the best. Thank you.
So with that, I'm glad I got to speak first and stay to my scripted comments. Looking at you, mad respect, mad love. You've taught me incredible amounts, and this is not goodbye, so it's all good. At this time, I would like to present a gift. And we're going to do public comment first. Okay, I'm sorry. Back, rewind, delete. Let me start that over. We're going to open it up for public comment. I'm going to ask if we can limit it, just because we are a little bit behind schedule, to 2 minutes, but I would like to open the line for public comment. So if we could do that, please. Kendra, if you could help me with that.
Yeah, we have one public comment in the room. Please go ahead, Stacy.
Thank you.
Ditto. No. No, Katara has been a role model and an inspiration to consumers all over the state, and I'm so pleased. We are very congratulatory about you going to SAMHSA, because I think she will hopefully be appreciated, and I know she'll be a leader there too. So thank you.
Thank you, Stacy.
Was that the last one in the room, Kendra?
Yes.
Okay, perfect. Now we have 2 online public comments. First, we have Richard. Your line's open. Go ahead. Richard, did that work for you? I'm trying to unmute you. If not, we'll come back. Next, we have Emily. Your line is open.
Good morning, everyone. I'm so happy to be here in this MHSOAC meeting to see that all the good words that are being said about Katara, because I would say that, you know, Katara is actually, I would like to say that, you know, Sally Zinman, if she were here today, I know she would be so proud of you. And I want to say from my heart that being on this peer movement at the same time as you, Katara, like, I'm not there in the room with you all right now, but I would be giving you the biggest hug, because I'm just so proud of you and the leadership skills that you've developed and your dedication to the state and the federal and all of us peers who have, you know, been victims of the psychiatric system. And so I want to thank you from the bottom of my heart, big hugs from Los Angeles. Thank you.
Thank you, Emily. I'm gonna try Richard one more time. Richard, it doesn't seem to be working. I'm trying to unmute you, but if you want to try again during the general public comment portion, we'll try again then. That was the last comment.
Thank you, Mariani. So at this time, Katera, I would like to invite Vice Chair Alvarez to join me as we present a resolution for you, and also Toby Ewing.
It's not working on my computer.
Excited to be part of, SAMHSA, the Office of Recovery, and work towards these missions that we have, and partner again continuously with everyone in our country and of course California. So thank you. It's such a huge honor. Thank you again. So. Bye.
Thank you, Katera. I want to welcome everyone again into today's meeting. The plan is to end around 3:30. Commissioners, if you leave the teleconference meeting for any reason and decide to rejoin, please make sure to use the raise hand function so the commission staff can make you a co-host again. If you have a comment to provide, please unmute your line and seek recognition when it is convenient. It is now time for agenda item 3, general public comment. This time is reserved for comments on items that are not on the agenda. If anyone is interested in making public comment regarding the announcements or other items, please make those during the general public comment time. If you have any technical questions, please contact us at 916-500-0577. At this time, I will ask Amariani to go over the public comment procedures.
All members of the public will have the opportunity to offer comment as described in the agenda. If you would like to comment on an agenda item, please wait until that agenda item starts. You may request to make public comment by clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. You will then be placed in a queue to comment on that item. When it is your turn to comment, the moderator will unmute your line and announce your name or the last 3 digits of your telephone number. When you are unmuted, we are able to hear you. We will do our best to take comments in the order they are received. Please note, once the public comment period for the agenda item starts, we will close the public comment queue, so please make requests to comment now. The moderator will insert the word "last comment" next to the commenter's name or number to identify the last public comment. Members of the public should be prepared to complete their comments within 2 minutes or less, depending on time constraints. When we have reached the end of your time, our staff will let you know, but we will let you finish your thoughts. We don't mean to cut you off, but we do want to help everyone keep time. We truly appreciate your understanding with this process. Lastly, if there are any members of the public using translation technology, please notify the chair, and at least twice the amount of time will be given to you during the public comment period. A live meeting transcription or closed captioning is available for anyone participating in the meeting. If that option is not currently visible, please activate the closed captioning feature located in the control bar at the top or bottom of your screen. We currently have 3 public comments. We'll start with Richard. Your line is open. Please go ahead. It doesn't look like it's working for Richard right now. Sorry about that. We'll try next. Emily, your line is open.
So I wanted to give an update with regards to all of my advocacy work since the last time that I came to this meeting on September 5th. I've been trying to figure out how to, without any help, how to figure out how to resolve my 5150 dispute caused by 988. I don't know how to navigate this system. Last time I said I don't trust it because I felt like I got raped by the system after being a speaker, a spokesperson for the Each Mind Matters campaign since 2014. And that was paid by CalMesa and the MHSA dollars by Proposition 63. I volunteered my time to be a face for Each Mind Matters, the California mental health movement. So I would hope that someone from the state could help me navigate the system for having been raped by the system in a 5150. And past Monday, I had a 988 webinar, a webinar about 988 sponsored by a group that is based in Massachusetts. They invited me to be a speaker, and we had 380 people, attendees across the nation sign up for this webinar. And so there is this book that I would strongly consider you guys consider. I blurred it out, but it says, "Your consent is not required. The Rise in Psychiatric Detentions, Forced Treatments, and Abusive Guardianships" by Rob Wypend. And so he's written articles that say, because of 988, 120% of there's been a rise of psychiatric detentions across the country by 120%. And so, Katera, I hope that we can learn to figure out how to fix 988. So thank you so much. And I hope to hear from someone soon from the MHSOAC, as I used to be the Client Family Leadership Committee member under Katera many years ago. Not too long ago, but maybe like around
Thank you,
2000.
Emily. Your time is up. Please wrap up your comment.
Yes, so I would appreciate some assistance from the MHSOAC to figure out how to navigate the system. So doing it alone, I can't figure it out. Thank you very much.
Thank you, Emily.
Next we have Steve. Go ahead, Steve, your line is open.
Hello, my name is Steve McNally. I'm from Orange County. I'm on one of your local behavioral health advisory boards, Welfare and Institution Codes 5604.2. Yeah, but my comments are my own. So first, I wanted to also congratulate Commissioner Tamplin. I couldn't figure out how to raise my hand, even though I've been on Zoom a lot. For just her willingness and openness and inclusion, being inclusive of all people. I remember, I'm not sure if I say the guy's name right, but Senator Brown and her and I were at a table eating at one of your local meetings. And I just remember it was pre-SB 803, and I was just amazed at just how easy it was to talk to them. So I appreciate that. I do have comments about Prop 1, and I don't know if this is the place for it or not. So if it's not, please let me know after I looked at your agenda. Hearing no, then I guess I will bring it up. And my big concern, amongst many others, is that most of the subject matter experts in the state have been embargoed from speaking, which makes it very difficult for the data to get out when negotiations were done in private for the most part. Also, I mentioned to your legislative person that I was concerned that Ballotopia has the OAC in a support position. And I know everyone else has been, and I'm sure it's fine the way it's done and all that. That's not my concern, but it's the most influential group in the state. And when other people have been embargoed, being associated with the topic publicly, it's difficult to see you there. And I know that's based on your support letter. And then lastly,
are up. Please wrap up your comment.
I will wrap it up. I sat next to Assembly Member Irwin, who couldn't explain the bond. And I'm concerned that we're going to add $4 billion of cost to the general fund when we implement it. Thank you.
Thank you, Steve.
We made Richard a co-host so that he could try and unmute himself that way. Richard, if you want to try unmuting yourself, you should be able to. We made you a co-host.
Good morning, Commissioner, staff. Can you hear me?
Yes, we can hear you.
Yes, I sent an email on January 18th to the commissioner and staff, and I have not received a response as an acknowledgement whether it was received and forwarded to the commissioners and staff. I wanted this to be part of the record with the minutes for this month's meeting in regards to Proposition 1. I'm greatly concerned about the buckets being reduced and the tapping the money for housing, including lockup facilities. Mental Health Services Act funding was not intent for lockup facilities with the beginning of this act, and it still should not be. It's just a political power grab by our government to transfer one funding source to another. And it's my understanding, I am not speaking on behalf of Cal Voices, they do not support this legislation, especially with the Oversight Commission being transferred under a state agency, which may put additional restrictions what the commission can and can't do. That's an area of concern. So I see their valid point on this. It's going the wrong way. It's going backwards. It's going into institutionalizations. We need more peer programs. We need more peer respite house programs, not the other way around. Thank you.
Thank you, Richard.
And that was our last public comment for this item.
We also have one in the room. Stacy, please go ahead.
Thank you. Thank you. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. Just want to wish the Commission a Happy New Year and look forward to working with you again this year. And I also hope that you will be making announcements about what is going on with the committees, particularly the CLCC or the CFLC, the Client and Family Leadership Committee, and the Cultural and Linguistic Competence Committee. Last year, I know the CLCC only had 2 meetings, and they were very important, and I really appreciate that. I hope that they can meet more this year because I think that committee and the CFLC are very important to the work of this commission. I also really want to thank the commission for putting on the agenda the evaluation report for the California Reducing Disparities Project done by the Psychology Applied Research Center of Loyola Marymount. Cheryl Grills, Dr. Cheryl Grills is dynamite, and I think you're really going to like that presentation. But I really want to thank you for putting it on the agenda for the entire commission because I think, again, it's very relevant to the work that you do, and I'm sure you're going to find the report and her findings really interesting. Thank you.
Thank you, Stacy. All right, thank you everyone for your comments. We are going to go ahead and move on. The commission will now move to agenda item 4 and consider approval of the minutes from the November 16th commission meeting. At this time, I would like to invite commissioners to offer comments or ask any questions. I see no comments or hands raised for questions. At this time, members of the public may request to make a public comment on agenda item 4 by clicking the raise hand button on your computer or the app, or if calling in by phone, by pressing *9. Are there any public comments? Please raise your hand now as the queue will be closing. Amadiani, Kendra?
No public comment.
Thank you. I would entertain a motion that the commission approves the November 16th commission meeting minutes.
So moved.
Second.
Thank you, Commissioner Rolette and Commissioner Bench. We have a motion and a second to approve the November meeting minutes. I would ask Maureen then that you please take the roll.
Yes. Commissioner Bontrager? Commissioner Brown? Aye. Commissioner Bunch?
Aye.
Commissioner Carnavale?
Aye. Aye.
Commissioner Carrillo? Commissioner Chambers?
Aye.
Commissioner Chen? Commissioner Chen? Commissioner Cortese? Commissioner Danovich? Commissioner Gordon?
Aye.
Commissioner Mitchell? Commissioner Robinson?
Aye.
Commissioner Rolette? Vice Chair Alvarez?
Aye.
Chair Madrigal Weiss?
Aye.
The minutes are adopted.
Thank you, Maureen. We will now move on to Agenda Item 5, the items calendared for consent, which includes the approval of innovation projects from Sacramento and Sutter Yuba. Commission staff have sent the documents related to these projects to all commissioners, and a copy of the staff analysis for both Sacramento and Sutter Yuba have been provided in your packet. These projects had a significant amount of community engagement, not only at the local level, but also through the commission's process, which is outlined in the document in your packets. The innovation project for Sacramento County was shared on October 20th, 2023, and November 13th, 2023, with community partners. The innovation project for Sutter Yuba was shared on September 25th, 2023, and November 13th, 2023, with community partners. No comments were received in response to the Commission's request for feedback for both of these projects. As a reminder, any commissioner can remove an item from the consent calendar. That item would then be considered as a regularly scheduled agenda item at a future commission meeting. At this time, I would like to invite commissioners to offer comments or ask questions. Seeing none at this time in the room nor online. At this time, then, we will have members of the public may request to make a public comment on this agenda item by clicking raise hand button on your computer or the app, or if calling in by phone, pressing *9. Kendra, are there any public comments for this agenda item?
No public comments.
Thank you. Then I would ask for a motion from the commission that the commission approves funding for Sutter Yuba County's multi-county FSP innovation project and Sacramento County's community-defined mental health wellness for African American, Black, African descent, unhoused innovation project.
I'll move the item. Commissioner Gordon.
I'll second.
Second, Commissioner Robinson.
Okay, so we have a motion and a second.
I will take the roll. Commissioner Bontrager. Commissioner Brown. Commissioner Bunch. Aye. Commissioner Carnavale.
Aye.
Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen.
Aye.
Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell. Commissioner Robinson. Commissioner Rolette.
I'm going to vote yes, but I want to note that in the voting on this, I abstained from the voting on the Sacramento project, as I did provide some feedback on the project in its inception, and so I want to make note of that.
Thank you, Commissioner Rolette.
I have you as an aye, Commissioner Rolette. Vice Chair Alvarez.
Aye.
Chair Madrigal-Weiss.
Aye.
The motion carries.
Thank you. Commissioner Chambers?
And I want to apologize, my vote still stands. The comment, because of my level of experience, one of my first projects as a young MPA was designing an African project for an innovations project. And I just designed it with the team. But one of the barriers that we saw in LA was being able to staff the organizations with people with that represent the actual population. So I just wanted to put it on record that if they could follow up with us on like ensuring that we have practitioners and individuals that implement this project reflective of the community, because I saw great disservices, I won't say the county, but definitely was barriers to being able to staff this, which I believe particularly impacted the outcomes when we don't have people that are reflective, just for the record.
Thank you, Commissioner Chambers. How do we, can you get an update on that? Or hear back from them?
Let me follow up with her.
I'm going to have staff follow back up with you, Commissioner Chambers, to ensure that we're following up with the team. And yes, thank you. And Maureen, I'm sorry, going back,
Pardon me?
Going back, it was approved, right? Both?
Yes, yes.
Okay, sorry. Went back to the conversation. Thank you, Maureen. Next, we move on to Agenda Item 6, the adoption of the Commission Strategic Plan, where the Commission will consider adoption of the Commission's 2024 through 2027 Strategic Plan. The Commission received a tremendous amount of input and feedback from community partners through the engagement efforts. To develop the strategic plan, the Commission staff consulted with numerous communities and multiple partners, reflected on the progress that has been made, and identified the right next steps for advancing transformational change. I'd like to invite Norma Pate, Deputy Director, to present the final draft of the strategic plan being considered for the adoption today. Please go ahead, Norma.
Can everyone hear me? Oh, sorry. Now you can. Thank you, commissioners and public and the members of the public for being here today. The purpose of this presentation is to provide an overview of the Commission's strategic plan for 2024 through 2027, which you will receive in your materials and which can also be found on the Commission's website. You can follow the plan and it will provide you with guidance through the process. During my presentation, I will summarize the role and functions of the Commission, provide an overview on the key strategies and initiatives outlined in the strategic plan, and highlight the goals and objectives. A question session will follow the presentation to allow the Commission to ask questions and seek clarification. Next slide, please. My sincere appreciation extends out to Commissioner Carnevale for his leadership in developing the 2024 through 2027 strategic plan. With Commissioner Carnevale's leadership, the Commission, in partnership with Boston Consultant Group, developed the first draft of the Commission's strategic plan and a framework as part of our strategic planning process. I would like to thank every member of the Commission who helped us develop this plan. I'm also so grateful for the time you dedicated to this project. The strategic plan would not have been possible without the efforts of and patience of our former employee and consultant, Jem Mayer. It is my pleasure to present, the next slide, please. It is my pleasure to present the Mental Health Services Oversight and Accountability Commission's strategic plan for 2024 through 2027. There is no doubt that the Commission is a vital part of ensuring mental health care is of the highest quality, accessible, and effective. As part of the Commission's efforts to fulfill its mission effectively, staff developed a comprehensive draft strategic plan for this period. Goals and objectives outlined in this plan guide the Commission's work over the next 4 years. As part of the process of developing the strategic plan, the Commission consulted with multiple communities and partners, reflected on the progress that had been made, and identified next steps. The strategic plan has evolved over the course of this process and should not be viewed as a static document. Next slide, please. Between May and November 2023, the Commission engaged the public in the strategic planning process. Several methods were used to engage community partners, including 40+ interviews, 7 public meetings, 2 online surveys, a focus group. This approach enabled diverse interest groups and racial and ethnic groups to voice their concerns. Slide 4, accelerating transformational change. Go back one, sorry, Cody. Okay, there. California's mental health system needs improvement. Mental health needs of Californians are growing, and transformative change is needed to meet them. Among the suggestions that will be explored in this document is a way to accelerate change in California's mental health care system and ensure that more people have access to mental health care in the state. There is no doubt that the Commission has been a driving force in promoting the Mental Health Student Services Act, working with pioneering counties to advance the use of early psychosis intervention, and promoting the use of youth drop-in centers to promote universal access to mental health care services. As part of its efforts, the Commission has also developed a state suicide prevention plan, worked together with communities to improve full-service partnerships, and coordinated crisis response. Initiatives like these demonstrate the benefits of developing comprehensive systems of care and promoting recovery and well-being. Next slide, please. In 2004, California committed to funding and transforming its mental health system, As part of its work over the last few years, the Commission has collaborated with the community and other government and private sector agencies to identify critical service gaps and provide technical assistance and resources to encourage a proactive, comprehensive approach to these gaps. As a result, the Commission raised awareness and elevated expectations for a maturing mental health system based on prevention, recovery, and resilience. Next slide. A key element of this plan is the fact that the priorities and goals it defines builds on the Commission's charge. It also has demonstrated a strong capacity to drive improvements and is committed to the MHSA's core value of person-centered and culturally appropriate care. Inequities and disparities will remain regardless of the results of the March election. Prevention, early intervention, innovation, and collaboration between agencies and communities are essential to reduce them. Next slide, please. It has been demonstrated through the Commission's portfolio of initiatives that effective community-based mental health services can prevent and reduce the tragic outcomes of untreated mental illness. A total of $442 million has been directed across the continuum of care over the last 4 years through the Commission's 10+ initiatives. The potential for transformational change demonstrated by these initiatives has also emphasized the urgent need for efforts in strengthening a comprehensive community-based system and bringing the issue into sharp focus for the near term. The Commission's North Star priority for 2024 through 2027 is to accelerate system-level improvements that lead to early, effective, and universal access to services. Initiatives and projects of the Commission will be guided by this priority. Next slide, please. This plan consists of 4 key foundational actions that will help achieve the North Star priority. Champion vision into action so policymakers and the public understand and support the development of effective services and supports to reduce personal suffering and the heartbreaking consequences of unmet mental health needs. Catalyze best practice networks to ensure access, improve outcomes, and reduce disparities, to close the gap between what can be done and what is being done. Inspire innovation and learning to close the gap between what can be done and what must be done. Inspire innovation and learning to, relentlessly drive expectations in ways that reduce stigma, build empathy, and empower the public to drive accountability for outcomes. Next slide, please. A fast-changing mental health landscape requires the Commission's special expertise. Despite the COVID pandemic, the mental health crisis has long been an epidemic. The state continues to face challenges such as homelessness, substance use disorders, and youth suicide. Services are difficult to access for marginalized LGBTQIA+ populations and California communities of color. Resources and practitioners in mental health are under greater stress than ever before. Managing change and demand will require California to develop a resilient system capable of directing and integrating resources. As a result of these trends, public agencies, including the Commission, will need to adjust their policies and strategies in order to adapt to the opportunities and impacts they will create. Next slide, please. California's mental health care is poised for historic change in the next 4 years. There has been a once-in-a-generation investment and public attention focused on an underlying in California. Ambitious collective action to integrate and improve that system in order to achieve significant change. A major objective of the Mental Health Services Act was to improve the funding, design, and distribution of mental health services through the use of local systems of care. In spite of that fact, the act was passed 20 years ago. It is still all too common for Californians to suffer from the 7 negative outcomes that it aimed to reduce. Next slide, please. Sorry. In order to achieve the vision of transformative change that the Mental Health Services Act has established, additional improvements need to be made to policies, institutions, agencies, and services. A transformative change requires developing a well-integrated, culturally competent system of care that is accessible to all, regardless of where they live or their cultural background, is necessary. Empowering communities, especially vulnerable, high-risk, and historically disadvantaged residents, so their priorities and needs are understood. As a result, they can participate in service design and advocate for improvements. In order to achieve better outcomes and continuous improvement throughout communities, services, and providers, state and local agencies and service providers need to be adequately resourced so that they have the capacity and workforce to manage toward better outcomes. Working closely with partners, the Commission will catalyze this change by strategically deploying its capabilities and working through partnerships. Next slide. In the past several years, the Commission has supported system-level change by working closely with policymakers to align funding and authority, by working with counties to build their capacity to better respond to escalating needs and address system limitations. As a result of this experience, the Commission was able to refine the core building blocks that will serve as the basis for its future activities. Next slide. During this process, the Commission's vision statement evolved. Our vision for the next 4 years is outlined in the plan. Next slide. The mission statement of the Commission has also evolved during this process, and by pursuing this mission, we will be able to effectively achieve our vision. Next slide. The Commission's guiding principles and core values reflect its aspirations for the behavioral health system and guide decisions. Authentic collaboration with diverse communities is required to reduce disparities and improve equity. Outreach and engagement with individuals impacted by the behavioral health system of care is an essential element of the program effectiveness. Tailored and culturally sensitive and competent services and supports are required for wellness and recovery. Accessible, affordable, and high-quality whole-person services and supports are required to improve outcomes. Public understanding and partnerships across agencies and communities are essential to aligning resources, improving services, and growing the capacities to serve everyone. A diverse, valued, and resilient workforce is foundational to high-quality services and reducing disparities. Innovation and continuous improvement are required to achieve individual and societal well-being. Next slide, please. The Commission has developed distinct roles for shaping policy and driving practices with the support of the Governor and the Legislature. By building understanding and championing a commitment to health for all Californians, the Commission drives system change. This plan aims to accelerate the adoption of best practices to reduce the consequences of untreated behavioral health issues, facilitate human-centered innovation, disseminate learning, and develop new administrative practices, services, and supports to address needs not met by the current system. It is necessary to track and communicate the status of improvement efforts, as well as recommend other reforms in policy and practice to understand and assess system performance. Next slide. As part of its mission, the Commission relies on a strategic set of capabilities and tools, driving policy through research, public engagement, policy development, and advocacy, driving practice that includes financial incentives, technical assistance, and evaluation, and driving transformational change through the assessment of system performance and opportunities for improvement. Aside from refining the Commission's roles and capabilities, these tools seek to enhance its abilities to determine where interventions will be most effective in decreasing harm. Next slide, please. The Commission aims to produce lasting system-level improvements by selecting, designing, and managing initiatives and projects. As a result, the Commission has developed a framework for decision-making. The goal is to find ways for the framework to evolve so that the resources can be allocated in an effective way. The framework will help the Commission identify which opportunities have the greatest potential benefit and design projects and greater precision to ensure sustained improvements in supports and services once the Commission's project is completed. The framework will increase alignment among commissioners and facilitate clear communication. Using the framework could improve the impact of the Commission's portfolio of projects and the success of individual projects. When the Commission selects new initiatives or investments or implements legislatively directed projects, the framework will be deployed, assessed, and refined. The framework also will be modified for selecting and designing innovative projects. Next slide, please. The plan includes 3 operational priorities: building foundational knowledge, using data-driven and community-derived information to drive decisions about finances and services to be adequate, sustainable, effective, and reduce disparities, closing the gaps between what is being done and what can be done by accelerating the adoption of effective programs. The Commission will reduce disparities. Closing the gaps between what can be done and what must be done through new approaches. The Commission will drive innovation in public-private financing, delivery of services and supports, and continuous improvements to accelerate early, effective, integrated, and universally accessible services. Next slide. The goals and objectives for the Commission will work with community partners, experts, governmental, civic, and other advocates to achieve the 4 goals outlined in its North Star priority. I will not go over the metrics listed on page 13 and 14 of the plan, but want to make sure that you're aware of the metrics associated with each of the goals and objectives in the plan. And it's anticipated that these metrics will evolve over time. Next slide. And the first goal is to champion vision into action. The Commission will analyze data and engage all partners to advance the evolution of policies necessary to provide an early, effective, and universal available system of behavioral health supports and services. To support these goals, the Commission will elevate the perspective of diverse communities, assess and advocate for system improvements, connect federally and globally to learn and apply. Next slide. Goal 2 is to catalyze best practice networks to ensure access, improve outcomes, and reduce disparities. The Commission will engage public and private partners, including universities and institutes, to catalyze the creation of best practices, networks of excellence. The Commission will focus first on networks supporting its semi-annual efforts in school-based mental health, early psychosis intervention, ALCOVE, youth drop-in centers, workplace mental health strategies, and full-service partnerships. Specifically, the Commission will advance these elements that are essential to system change. To support these goals, the Commission will support organization capacity building, fortify professional development programs and resilient workforce strategies, develop adequate and reliable funding models, support system-level analyze to ensure the tailored care and universal access required to reduce disparities. Next slide, goal number 3 is to inspire innovation and learning. The Commission will develop strategies and partnerships to catalyze innovation and accelerate the development and dissemination of new models and practices that further improve behavioral health and well-being. To support this goal, the Commission will curate an analytical-based narrative on the potential for innovation to improve behavioral health outcomes, establish an innovation fund to link and leverage public and private investments, accelerate learning and adaptation in public policies and programs. And the 4th and final goal is to relentlessly drive expectations. The Commission will work with all Californians to increase understanding, empathy, trust, and empowerment as a way to bolster public ownership, expectations, and accountability for improvement of the public behavioral health system. To support this goal, the Commission will launch a public awareness strategy to reduce stigma, promote access care, and communicate the potential for recovery, develop a behavioral health index, and promote understanding of the progress that is being made and the advocacy that will result in further improvements. Next slide, please. From plan to action, as part of the Commission's efforts to accomplish the goals and objectives outlined in the Commission's 2024 through 2027 strategic plan, we are strengthening our internal project management, human resources, community engagement, and communication protocols. Throughout the implementation process of this strategic plan, the Commission will conduct regular monitoring and evaluation to ensure that it meets its effectiveness and accountability objectives. As part of its performance and evaluation process, the Commission will establish clear performance metrics, track progress towards goals and objectives, and adjust as necessary to ensure continued improvement. The goal is to return to the Commission in the coming months with an implementation plan for the appendices section of the strategic plan. We will discuss how our work and the work of future committees supports the goals and objectives listed in the Commission's strategic plan. Also included in the plan, next slide please, we have documented our learning from the public engagement that we conducted for this plan, and the summary of themes from our community engagement are listed on page 15 and 16 of the draft strategic plan. And I want to thank our community partners that took time out of their busy schedules to help staff develop this plan. Thank you for your time today, and now I am ready to answer any questions you might have.
Thank you, Norma. At this time, I would like to invite commissioners to offer comments or ask questions. Please, Commissioner Carnevale, and then Commissioner Bunch, and then Commissioner Chambers.
So I just wanted to, since I started this process for this cycle, I wanted to make a couple of comments. First of all, I think the commission, I thank you for supporting what is a different approach to strategic planning. I know strategic planning isn't always the most exciting thing for people to talk about. As your business representative, I live in this a lot in my day job, so I get more excited about this than probably other people do. But here's why I think it's important in the context of what we're doing. You know, we live in a world where everybody knows that government is often challenged, and we certainly know in the behavioral health system it's broken in so many ways, and seemingly half of the country now seems to want to just tear down government. But I think this commission and everybody here that I know of is working hard within the system to try to make it better, and the importance of the strategic plan is to do exactly that, try to deploy our resources so they're being spent more effectively and more efficiently, and systems are being aligned more and integrated more. And we've got a long way to go in the mental health system, but I think that where this plan is landed gives us an important framework to be able to think about. You know, we have a wide range of programs that we're engaged in, and trying to understand what they all mean in total is not easy. I think this framework helps us understand that a little bit better. I just want to acknowledge that and this is not unusual, my vision for this was probably bigger than the resources we had. I had hoped that out of this process we would have more of a quantification to a lot of this framework, but what we found as we got into the program, we actually didn't have enough money invested in getting to that quantification. But I see that as a next step. We can hang on to this framework, a quantification of the problem and the solutions that we're providing and what they mean in the context of the problem. And then I think there's a third piece, which is to create some outcome-based measurement systems, which I know we are in process of considering and we'll talk about in some future meetings. But I think this is a great beginning of the next phase of the commission to lean in even more heavily to lead and catalyze innovations that I think can make our system more effective and more efficient at a time when sometimes the problems seem so challenging that you wonder if we're even making progress. But I think we can make progress, and I applaud everybody's effort here to support this program and this plan. Thank you.
Thank you, Commissioner Carnevale. Commissioner Bunch, please.
Thank you. I just wanted to see if you could say more about the behavioral health index that's going to be developed.
Thank you, Commissioner Bunch. So the way this is structured is there are 4 goals, as Norma outlined those, right? And then within each goal, we identified a series of objectives. And for each objective, we're working on developing metrics. an index or indices are sort of classic strategies to really understand, how to measure and report out. So the good news is there's a lot of work that's been done on that in the United States and around the world. The challenge is California has never really been successful in developing an index that is consistently tied to policy and practice. And so over the course of the next, it's probably going to take us a couple of years, but it's tied into the language of the law today, the Mental Health Services Act, and it is being restated in Prop 1, should it pass, that California will build a robust accountability system. We're already working with the governor's team to frame out what that looks like, again, because it's in current law, it's being restated in the behavioral health reform. So the goal, and we're not done there, is to develop that metric, that indice, so we have those metrics in response to the comments we've heard from commissioners and the public that you want a stronger sense of the impact that we're having on behavioral health outcomes. And you also want that index to be helpful in terms of shaping the decisions that other entities are making, like the legislature, the public, around funding, policy, practice, interventions, et cetera. And so that's where we are. And so it's an aspirational component of this facet of clear goals, a small set of clear objectives, and then our capacity to actually measure progress against those over time. Does that help?
Commissioner Chambers and then Commissioner Danovich, please.
Just to highlight the work that the commission has done, but also, I know there's some conversations about how the committees can support this work and putting it into practice. My only challenge I have, or commission that I have for the staff, is to really be able, like Norma is envisioning, to provide an implementation plan that'll really give us some guidance, because strategic planning documents are amazing, and I'm happy, Carnivale, that you operate in that. But for someone in my field, we always create these documents. It's okay, give me my marching orders, and this is my thing. But then also having a balance between in the committees addressing some of the ever-present challenges that are going on within our fields, but having the balance of it also adhering and trying to achieve or implement some of these goals. So I'm looking forward, and I can commit with an implementation plan to support this work and best support it in the committees as well. Just wanted to put it on record that I'm looking forward to a viable implementation plan.
Thank you, Commissioner Chambers. Commissioner Danovich, please.
Yeah, comment and question, really that similarly aligns. First, the comment is just, huge kudos. I think it's a great document. It's compelling and coherent and concise, and the language is really clear and specific, and that's not easy to do and achieve. And having seen different iterations of strategic plans, I think this one really reflects a understanding of this kind of complex space of where the commission sits in our behavioral health policy, health ecosystem, and what levers and tools we have and what constraints we have. So I think that that's really pragmatic, practical. Really glad to hear that there's a goal to develop performance and outcome metrics. I think my question is really along the lines of Commissioner Chambers, which is, in the interim, what's our plan to hold ourselves accountable to this plan? Because I think we still can, we can design something to help us make use of it. And then just one other comment, I guess I would say, I know that there was some, concerns were raised, or not concerns, or questions were raised about, is this the right time for a strategic plan given all the things they may change imminently? And I do think that these plans are valuable, going through these motions are valuable, even if everything's going to change. Sort of steering ourselves as best as we can all the way through that change helps set us up for what happens to come. So, thank you for taking that on in this additionally uncertain time.
Thank you, Commissioner Danovich. And I know we have had some discussion, we're not waiting until this all is in place and go. What are we going to be doing in the meantime? And so, Toby, I would ask that you respond, please.
I asked if I could avoid answering that question, and it,
I said no.
So it might be helpful to understand kind of the trajectory the commission has been on. When I first joined 9 years ago or so, the conversation with our colleagues in state government and in the community was really about the commission's job was to monitor the expenditure of Mental Health Services Act dollars. And Maureen and I had a very lively conversation on the plane down here yesterday, such that people around us started to sort of weigh in as we got off the plane. But the Mental Health Services Act dollars go to counties, and they're about a third or so of overall funding, depending on the county, maybe a half. Counties are responsible for the serious and persistent element of community mental health. They're not responsible for all community mental, they're not responsible for Medi-Cal managed care, for example, right? And they're not responsible for the community mental health that is through public health or develop prevention or intervention. So, the sort of two strategic planning periods ago, the conversation was the commission really looked at about 5% of what was happening in the behavioral health space because the focus was on the dollars. During the last strategic planning session led by our former chair, Lynn Ashback, you landed at ensuring care for everybody who needs it, this population health perspective. And that was a big shift. And there were concerns about accountability and, are we making progress? And I would say, with complete confidence, we've made tremendous progress. The school mental health work is beyond the sort of traditional domain of county behavioral health departments, where that focus had been for so many years, even though the Mental Health Services Act says prevent school failure. Aggressive prevention strategy. We've written a prevention report. We're doing workplace mental health. Over the last 4 years, we really have pushed towards this population health strategy, and the commission, you have really been able to push our counterparts in county, state government, right? The numbers of partners we have in law enforcement, public safety, more broadly defined, 988 response, right? If you look at the four keys here, champion vision to action, catalyze best practice networks, inspire innovation and learning. The subsets here, catalyze best practice says to ensure access, improve outcomes, and reduce disparities. It's really, and the second one is, close the gap between what can be done and what must be done. The idea here is we know a lot about what is effective, but it's not yet available in our communities. And so that's one of those four. The second, that's number two. The third one is, what about the things that we're not quite sure how to do well yet? How do we really drive to close the gap between what we know how to do versus what we should be able to do, sort of the innovation piece that Commissioners Danovich and Carnevale have really been pushing on. So, we want to be able to, we're trying to do a couple, I'm saying this to say this is big, this is difficult, right? It is not fully within our ability as a decision-making body for the commission to actually achieve these outcomes, right? It is really, as you've said, Commissioner Danovich, about inspiring and motivating and catalyzing change beyond our internal operations. We've been able to do this very successfully for the last 5 or 6 years. I'm confident we'll be very successful moving forward. We're trying to do a couple of things to get very precise in terms of the answer to your question. One is to develop the metrics that will operationalize the strategy that the staff pursues moving forward. We haven't developed those yet because there's a lot of work there. We wanted to make sure that we had the goals, the objectives, right, this vision piece correct. Staff is working on 4 operational plans. One is the operational side of the commission's activities. 2 is communications, outreach. 3, public engagement. 4 is Norma's area around personnel, our internal capacity building and how to do that. We've also been talking consistently with the chair and commissioners who are interested in chairing the CFLC and the CLCC. Stacy had asked a question about the committees earlier today. I'm hoping to have all that wrapped up in February. We weren't able to make it happen today. but wanting to engage the committees to help us ensure that we are accountable to the game plan that you adopted should you adopt it, right? And so that's to say, we're trying to figure out the answers to those questions, knowing that some of the answers will be inadequate, because we are challenging ourselves to close the gap between what we know works today and what we should be able to do tomorrow. That's a big task, right? That's the saying. Part of this commission's job is to inspire innovation, to move us beyond best practices where we don't have them at the moment.
Just one brief follow-up comment, and feel free to dismiss this because it's just a suggestion, but what I had in mind, even with the document that exists, there's kind of the high-level goals, there's some tactics that are specified as, it might be possible to just have some score sheet around those domains that have green, yellow, red. Green, things are going great. Yellow, challenges, red. We really need to elevate this, and it may be a way for us, commission, to review it at a glance and know what do we need to elevate to talk about because we're having challenges. What's going great we don't need to talk about, and we just need to show off, and then what's somewhere in between. But it just at least keeps forest versus trees aware of this stuff and gets us in the practice of using these tools to help drive our prioritization decision making. Just a suggestion. No need to respond.
No, absolutely. And where we're making the most progress is on the community engagement piece. And so we're actually working to roll out a dynamic mapping tool that allows us to monitor quarterly our community engagement efforts. So, but yes, we are working to create that sort of results-based accountability scorecard strategy. But we felt it's too early, given that we weren't sure we were on the right targets and wanted to get your feedback. So thank you very much, sir. And we'll ask you to weigh in and help us develop that so it's responsive to the vision you have.
And I think we talked about that too, Commissioner Danovich, like the dashboard almost, when we talked about what that would look like and measuring it. So thank you for that. I have Commissioner Vice Chair Alvarez and then Commissioner Mitchell, please.
Thanks so much. And my comments build on both Commissioner Chambers and Commissioner Danovich. My first reflection does raise this question about the committees and the opportunity we have to engage the expertise of our committees in assessing our progress towards whatever identified metrics we move forward. And I would love to explore what that actually does look like in practice, right? So that we do feel that the use of our time together is productive and contributing to these goals and activities. I recognize community engagement is a great component for our committees, but so are these other areas, right? Whether it's our internal operations or our innovation. I mean, there's expertise from those committees on each of those components. So want to just drill down that point. My other question, I have a question and a suggestion maybe. My other question is, to Toby's point about alignment with other initiatives that are happening across the state. I fully appreciate that we can only control what we do, right? But we are within this broader ecosystem of mental health services and supports that the state is moving forward. So finding ways to help us understand, Norma, how our strategic plan furthers the master plan for children's health, the Children and Youth Behavioral Health Initiative, right? That is one-time money of $4 billion. Ours is not one-time money. So then what does that mean for the long-term system change that we want to make happen? How do we leverage that opportunity in alignment with our strategic plan goals and helping us as commissioners understand that so we can be ambassadors for that and we can tell that story along with you all, right? So that was my suggestion or question. And then, to this point that both the chair and Commissioner Danovich said, perhaps at our commission meetings, maybe once a quarter, can we have a look back, a reflection time where we say, here's the progress we've made, here's what's happened, the red, yellow, green, in order for us to hold ourselves accountable and hold the public or have the public hold us accountable and offer some transparency in that report out.
That's a great suggestion, and, we are working on, we worked with Commissioner Danovich towards the end, like after our January meeting, to develop a scorecard, and it was kind of, too late in the process for the last strategic plan for us to really implement that, but we definitely are going to be reaching out to Commissioner Danovich again. Hopefully he'll answer my calls, and developing that scorecard, and then bringing that to the commission. And if we've missed something, we can definitely go back and refine it and bring that back, so that we're keeping track of everything that the commission feels is important to the commission, and where you want to see progress being made. We'll include that in our scorecard. And we're also, again, on our internal plan, we're working on ways that we better internally even communicate on our projects that we're working on,
Right.
and what needs to be communicated to the commission, and thinking about what we need to bring forward to you all.
Can I just comment on that point briefly?
Sure, please.
Yeah, I just wanted to say that if we're doing this right, we're not establishing metrics that are within our silos, but we're really measuring metrics that are about the entire system's performance, so that we can then measure our specific activities against the whole system. And then you've got, I think, what everybody's trying to get at here, to understand what our impact is at a system level.
Absolutely.
Thank you. Commissioner Mitchell.
Yeah, I hope I can articulate what I'm thinking, because I think the strategic plan, I love the work, I love the thought that's gone into the goals and the projects, but because again, I represent families that have, experienced with a loved one with a severe mental illness, so I'm gonna always come from that perspective. And so in looking at the work, my hope is that when these strategies are being put into place, as well as the goals, that we're always keeping in mind, how does this work impact the consumer? Because this is such a macro project. I mean, these goals and strategies, they're so big. I think a couple things. I think alignment is so important. So if this work could somehow create alignment across the state, that all counties are in alignment with what we're trying to do, but also a consideration, and I don't know how you measure that, but to have the family's voice or the consumer's voice at the heart of this, because that's who we're doing this work for. I mean, the goals, the plans, they're innovative, they're magnanimous. I mean, they're huge, but at the heart of this, at the end of the line, we're doing this for people. And so we have to be in that mindset when we're creating this work. And so that voice has to be in the mix. It has to be there. It has to be at the table. It has to be heard. It has to be the consideration. How does this impact that family that needs these services, whether it's the mental health piece, whether it's the homeless mental health, whether it's the addiction piece? At the heart of this work is the consumer. So that's always going to be my ask, because this is beautifully laid out. But are we in alignment with the people who need these services? And just, can we get some consistency across the state? Because every county is different, everyone does everything different. But at the heart of it, the consumer in LA County and the consumer in Alameda County, Yolo County, when families are in crises, it's all the same. They want to know, where can I go? How can I get some immediate care? Where do I go to deal with these problems? So I know, again, our perspective is macro, but we're in the trenches when we're in need.
Thank you, Commissioner. The way this is structured, particularly Goal 2, catalyzing best practice networks to ensure access, improve outcomes, and reduce disparities, it's not the only place that your concern fits, but it is an example of how we're trying to translate the passion and the perspective that you bring into the strategic initiative or the opportunities that the Commission has. So I'll give you an example. Currently, we started working to improve the quality of care available to people in the early stages of a psychosis diagnosis, right? Our research partners tell us, at best, 5 to 10% of Californians have access to best available care. So the way this is designed is for the Commission to really be pushing to move from 5%, and this is getting to the dashboard kind of conversation, to 10 to 15 to 50 to 100%. On the agenda later today is a budget ask around some research that we are proposing to do that would help us develop a game plan to get from 5% to 100%, right? I think the sort of the pivot, and it's not a complete pivot, but it is a conceptual shift, is rather than the Commission providing a small amount of funding in order to launch 2 additional or 5 or 10 additional early psychosis clinical sites, which we've been able to do with the funds that we received from the legislature, the research suggests we probably need 300. At the pace we're going, it will take us 20 to 30 years to get 100%. And so what this plan envisions is our capacity through community engagement by looking at best practices, that goal that says look at what we're doing today versus what can be done today, and that goal of looking at what can be done today versus what should be done today. The intent is all of that, each of those 2 main pieces is informed by the perspective of clients and families, right? Really looking aggressively at the impact that inadequate access to care is having, doing the economic analysis, building the political support, building the public understanding so that the expectations that you have are the expectations that are driving decisions from the smallest decision in the local community to federal or global decisions, because we've been having some of those conversations as well. So I'm hoping I'm answering your question with the example of recognizing that this work starts with recognizing that our families too, meaning my own and our staff, have been in that position at 3 a.m. and not knowing who to call. And we don't want to just take dollars and spend it to create a patch. We want to change the way the system is designed so that we're not creating a quilt of patches, but we're creating a system that is much more responsive to high-level goals, so that consistency, right? Everybody who needs care should get care. It's still that sort of, broad goal, but the strategy that's changing, and it's a slight pivot. It's more about how we talk about it, but what we're looking for is guidance from you. Are we on the right page? That we would aggressively move towards consistency, reliability, competency, and capacity that is population-based, rather than saying, how can we best spend $20 million a year, right? How do we use those funds to leverage all of the other funding? So Commissioner Carnevale's work on innovation, the conversations around brain capital, the discussions we had with the United Nations, our partnerships with public safety, with education. These are, with the support of the chair, we're working to operationalize workplace mental health standards for teachers and education employees. We're talking about doing that across university systems. We're talking with the University of California about building a center of excellence on workplace mental health so that every employer recognizes an obligation to be a champion for mental health. So it's, so all informed by the perspective of what recovery means. Does that help?
It answers the question. I wish we could, and maybe I'm really being unfair, but I wish I could measure that. Measure your, we can.
We can.
Not today,
Not today,
but it can be measured. And that's the goal. And so we're having, so part of the conversations around community engagement is, should we be sponsoring an annual survey? We have a project now to do, that is part of a legislative conversation around universal screening in schools, right? We're not, the state of California does not seem to be ready to go there because they're concerned about the capacity to respond to those needs. But we're on pace to issue a preliminary report in February or maybe March, actually, on how to get there. And so there's a lot of work to do for Commissioner Danovich, for you. We too want to be able to measure progress.
Add to that, Toby. Also, in our plan, if you look at the themes that were created at the end of the strategic plan, we're going to be, working on our implementation plan for how we engage with the community, and we want to bring those voices back to the commission and creating ways that where we can share what we heard, not just reaching out to the community and engaging, but bringing that information back to the commission. So that will be part of how we implement our community engagement plan, looking for opportunities to hear those voices.
Commissioner Chambers, please.
I don't mean to drag on, but I mean, Commissioner Mitchell, I think you hit something on the head, nail on the head. I just wanted to commission us to work together more effectively relative to consumers and family members to this whole scope and framework, because what I'm seeing in our industry is a big opportunity for the populations that we both advocate for to be have more opportunities to unite so that we can gain better feedback and traction. I don't know, I just think that at the framework of this, I believe that there's going to be a bigger need for consumers and family members, which we have so much in common, more in common than what, is being, I don't know, put out in here. So I'm putting it on record that I am committed to working across the board, and as a workforce, I believe there's a lot of opportunities to be able to bridge that so that we can have, I feel like, a stronger voice relative to these strategic goals, because there just needs to be more alignment amongst that. So I don't know if it's like, I'm not trying to put you on a committee or committee assignments, but I just want to put it out there because there definitely is across our workforce, and there needs to be more work done with consumers and family members. There is a divide, and I believe that we have more in common than we have not in common. So just want to put that on public record. If there's an elephant in the room between the consumers and family members, and relative to these goals, I feel like they're all aligned together. Thank you.
Please, Commissioner Carnevale.
I just want to say I love this because this to me is where the strategic plan comes alive, where the numbers meet the needs. That's when I get excited. And this is what frustrates me in my day job. In business, if you're in charge of the sales of a Snickers bars, you know where they're sold, who buys them, why they buy them, how often they eat them, why they eat, you know everything about it. And you have goals and measurement systems that you're measured against to drive those sales. We have something as important as mental health, and our system doesn't measure it. We don't know how big the problem is. We don't know how much progress we've made or not made. We didn't know anything about it, which is why I get passionate about specifically to create a system of measurement and outcome-based management that we can actually drive improvement, which government doesn't do very well. And if you do all that at a macro level, you get down to delivering more services more effectively that people themselves need. This is all about delivering to individual people. Thank you.
Thank you, Commissioner Carnevale. Commissioner Brown.
Again, I don't want to belabor this, but I just wanted to take a moment to thank, in particular, Commissioner Carnevale for getting us focused on this. As you may recall, I was one of, if not the most vocal about being skeptical about the strategic planning process, having been involved in several previous, very, very difficult strategic planning processes that ultimately became relatively useless because of changes that occurred in the environment and the economic issues and so forth. I think this plan is a good balance between a traditional strategic plan and really something that will serve as a roadmap, but is flexible enough to be changed, and we can be nimble as we address the challenging changes in the environment that inevitably are going to be thrust upon us. And we didn't end up with something that was the size of a Sears and Roebuck catalog or a telephone book. And I say that with full understanding that half of the people listening are not going to know what either of those two things are. But this was the problem, I think, in the past, that we would just make these gigantic plans that would sit on a shelf and gather dust, and nobody would ever look at them again. And the whole situation had changed. And I think really these goals and these objectives particularly can serve as our guiding principles as we move forward. And part of the process obviously has to be the feedback loop, the analysis that has to be done to see, are we being effective? And I think the desire is there to do that. The resources are going to need to be there as well, obviously, but I think that I just want to commend everybody that worked on this, that I think this is a good balance.
Please, Commissioner Rolette. Thank you, Commissioner Brown.
So I'm going to continue with the strategic plan on the shelf metaphor, and let me just say, from the perspective of one, that I do know what the Sears and Roebuck catalog is, and I actually bought the Buster Brown jeans to prove that I know that. So I understand that there are elements of the strategic plan that specifically are under the Commission's direct purview and under the Commission's influence. And again, because Steve has been instrumental in developing this plan, I want to say that I also understand the importance of really understanding the context that we live in today, that today's reality tomorrow might change. We know that. And so to have a static plan that becomes obsolete tomorrow is not the goal, and that's not the goal of business. And that's Steve. That's the way, and I appreciate that. I also appreciate that staff are receptive to those influences and impacts. So I'll succinctly then, specifically, and then succinctly focus on the North Star priorities that I hope, here's my recommendation, that I hope the North Star priorities get incorporated into your report card, if you will, because from my perspective, the perspective of one, that's why Sears and Roebuck's catalog was useful to me. I didn't look at that whole thing. I just looked at what I wanted out of there. And that's what the public's going to look at. They're going to look at what they want. And that's to reduce, to understand, and close the gap. Are you doing that? And that you articulate that message in a way, in the same way business articulates the message that I understand why you buy Snickers, where you buy Snickers, and when you buy Snickers. And I understand the needs that you have around ameliorating the unique challenges that you have in getting your behavioral health needs met. And we want to do that for everybody, even for those people who utilize services that we only have impact, that we're privileged to have impact over. And let your report card talk about that very succinctly, and to do that in a way that it resonates with consumers and families. Do that. And if we could accomplish that as commissioners, and then tell me what committee, what role you want me to participate in, to help advance that objective, I get excited about that. Because like Commissioner Brown said, I'm not taking the entire catalog around with you, but those components of that report card, I'm going to talk about everywhere. And I'm going to tell people, this is what the commission is doing, even in light of the changing landscape in California. Thanks.
Thank you, Commissioner Rolette. Okay, so I don't see any comments or any hands raised online. I want to thank staff for all the work done. I want to thank the Commissioner Carnevale for your leadership on this. And I just want to, just in reflecting from the earlier strategic plan we had prior to this, the differences I really see here is the community engagement, I think, was huge. I think it was just the fabric of what really put together and helped inform the strategic plan. Agree with you that this is succinct, concise, goals, objective, metrics. We've got it. As I've been working with the staff and hearing updates about this, key was how valuable the community engagement was. And so I think that makes a huge difference to where we were before, so I appreciate that. And I will task this commission that continued to be the priority, because this isn't about just the system, this is about the people of California. So I think we need to make sure that remains our priority all throughout. Our committees need to really hold us accountable with the strategic plan as well. So I'm looking forward to that. And as we move forward, we need to continue to create opportunities where we hear from our communities, our families, our consumers, and not just within the committees, but how do we create opportunities to go into our state in places that aren't necessarily just the commission meetings, but how do we create those opportunities where we hear from our families? And for those that can't be in these commission meetings, but how do we do that? So I want to make sure that we keep that a priority. So again, thank you, Commissioner Carnevale, staff. Great job, great job. Thank you so much. So at this time, we are going to invite members of the public to request to make public comment on this agenda item by clicking the raise hand button on your computer or the app, or if calling in by phone, *9. Are there any public comments? Please raise your hand now as the queue will be closing. Kendra.
We have one in the room to start with. Stacy, go ahead.
Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I really want to congratulate the Commission and particularly Commissioner Carnevale for leading this effort. I really felt that the Boston group, or I'm not sure if that was that they did a very good job of community engagement and reaching out, more so than in the past, or with other commissions that I know where they really don't do. And I really felt they had a commitment to listening to BIPOC and LGBTQ plus and other underserved communities. And I think it shows because I am really impressed with the language in your North Star priorities, your commission's vision, mission, and guiding principles. It is something that I feel shows a commitment to reducing disparities and listen to community engagement. So I really want to commend you on that. And I really also want to commend the commissioners on your comments. They were also relevant and made me feel, again, a part of this where, you were talking about measuring and, is this something real? Is this something that relates to consumers and families? All of your comments were really good. So again, I just want to thank you and congratulate you. And yes, I also do want to thank Commissioner Brown for the Sears Roebuck reference, because being from raised as a little girl on a farm in a very rural area, that was very important, and I remember that in the Montgomery Ward's catalog very, very well. So anyway, but thank you and congratulations on this work.
Thank you, Stacy.
Okay, we have 4 public comments online. We could start with Richard Gallo. Please go ahead.
Hello, can you hear me?
We can, Richard. Go ahead, please.
Okay, good morning, everyone. I strongly support this being done by the commission. It needs to be done. I critically like the commissioner's response to meeting the needs and the voice of consumers and families. That's one of the things that's felt lacking by the peer community, the feedback that I get. I have a lot of individuals and families telling me, you're wasting your time with the Oversight Commission. They're not listening to you. They don't care. It's waste of time. But yet I continue to show up to the commission meetings to voice my concern as a person with lived experience, as a peer worker, as a Medi-Cal peer support specialist. And I echo Stacy, what she have stated earlier in regards to the commission and its report. I remember when this was first brought up, that there was hesitation and reservation within some of the commissioners on the commission. I'm just glad that they able to see and be more open-minded, the rationale for this, the need for this. When Governor Newsom made his Proposition 1 support in Los Angeles County in a hospital, one of the things that he mentioned regarding the lack of transformative change within the unhoused community, which is why he's making the legislative changes that he proposed and want with Proposition 1, because it has not been transformed within our unhoused mental health community. Part of the act was to serve the SMI unhoused community. That's all I have to say. Thank you.
Thank you, Richard.
Next, we have Steve Leone. Please go ahead.
Yes, hello, can you hear me?
We can, Steve. It's just a little difficult. If you could speak up, please.
Just a little better.
Better.
Okay, I'll do my best. First of all, I do want to echo good work, but I want to add something in here as well. I want to refer in particular to the slide in the presentation that says operational priorities. And you started about talking about build foundational knowledge. And, you know, I think a lot has been forgotten. Changes that have happened in the 20 years since the MHSA was passed, or, well, actually, since the prior group, AB 34, the prior legislation, which was the same, have not just been changes in the system, but there's been a fall off in the understanding of what was originally intended. 2 past governors actually ate into that process. Won't go into detail. Exhibit A would be, I think, Toby, you referred to this kind of thing, saying the full service partnership outcomes from early on were a lot better than they are now. So I think I would talk about, it's hard to do system improvements, and you're also dealing with system disimprovements. And frankly, a lot of that has been on drift for the last few years. And the governor's thing actually cements some of that drift. One of my biggest concerns is that it cements like things that are going to be less effective for people than are the case now. And closing that gap between what's being done and what can be done, et cetera, is going to be even harder. And you're going to have to work even harder to recoup the lost directions here. And I'm hoping, I don't have time to go into kind of details, so this may seem a little disconnected, but I'm really hoping you pay attention to those kinds of things. Thank you.
Thank you, Steve. Steve, I'm going to ask you, in the very beginning, you were specific about what are the slides. I'm going to ask you to also email that in to the staff so that we can be clear about the
It's
message.
the operational principles. It's on the slide deck for the presentation of the plan.
Thank you. I'm still going to ask you to, if you could email into the staff, just so that we can be clear. Thank you, Steve.
Is my voice that bad?
You know what, there's just, it's not an echo, but we just want to make sure that we get the message right.
Okay. And
Thank
I
you.
would actually, in a moment here, I got a lot of this knowledge. For those who don't know, I worked with Rusty Felix and Richard Van Horn, former commissioner. Like, I was on the board of directors with them at MHAC starting back in 1997, and I was connected with them until Rusty left and Richard died. So I learned from some very good people. So thank you.
Thank you, Steve.
Okay, Steve McNally, please go ahead.
Thank you. Following the one Steve. Again, I'm Steve McNally from Orange County on a behavioral health board. My comments are my own. I do like the document as far as crystallizing the thinking. I am concerned that there are variables beyond our control, and that's that I attend a lot of meetings, and there's a lack of safety of people being able to speak without fear of recrimination. And it goes earlier to everyone being embargoed on Prop 1. But sometimes, we talk about parking lots. That's easy. Great idea for another day. But we also have to worry about how meetings get hijacked. So I would ask for a couple so that they get hijacked, put those in a parking lot as well, like chronic issue known, but not for today. So I'm going to make a pitch or an ask, and that's to connect yourself with the Behavioral Planning Council, to connect us to the local boards so that we're in sync. And it was good to see the chair and Toby at the Planning Commission meeting to talk about youth, and it was a great presentation. I made a very good contact to coordinate something for one of our supervisors. But, there's 900 plus of us, including 59 electeds at the local boards. And so many times we all are still struggling, like some of the comments you made, where is all the information? So I would ask, somebody had oversight and accountability for data collection in our state and distribution of it and level setting for all parties involved. You might find out who had that and find out why it didn't happen. Because we're still faced with a lot of things that are embargoed as far as data is collected but not shared. You can find it in that open data portal. But we're not playing, politics is taking over, and it really hurts my family, my son. When I don't have a problem navigating, I've never had a problem navigating the system since I've been involved with it. And yet no one says to me, why do you not have a problem? So I'm going to ask you to model the behavior that you want too. And, if we don't want stigma, we have to be able to eliminate self-stigma. And so there's just certain things where I feel like families and peers have been pushed aside.
Please wrap up your comment.
I'll finish up, because we're so focused on youth. And I think youth is great because they don't create baggage and they don't have to get rid of baggage. But I think everyone's sort of been pushed aside on community planning. And I don't know if there's a safety space where people feel they're being listened to. Otherwise, we wouldn't continue to bring up the same things over and over and over again. Thank you for all your hard work. I appreciate it. Have a nice day.
Thank you, Steve.
Okay, our last public comment, we have Emily. Please go ahead.
Thank you for all of these conversations. I appreciated what Rachel said earlier about, we all have more than common than we don't. And I think I would hope that we would all want to trust the system and to be able to feel emotionally safe and vulnerable to, but I liked how, we had a discussion about alignment and we're talking about accountability. And then one person mentioned how Katera, she has this hope. And, to be very honest, when I was a member of the CFLC, I had so much burnout because I overmaxed my mind with too many meetings because I just care as a person who really cares about people not killing themselves. And yet I was 5150'd in a moment of shock and grief and missing my dad because he's been gone for over a year now. And I've been doing artwork for him and even showcased it at Rachel's Painted Brain space. And I did 2 national speaking engagements within the last 6 months with NAMI National and then with Wildflowers Alliance, and to talk about important topics about grief. Grief is not even talked about enough in our own all culture, but I also have a question. Does the MHSOAC keep any of the healthcare hospitals accountable, not just state, but the private institutions? And that's the navigation that I have such a hard time with. And no one's, even though an LA County Department of Health is unable to assist me to find a patient's rights advocate, I've been doing this work on my own to the point I spent a whole day in person at the LA County Board of Supervisors meeting to tell my story and to also help to be up for the implementation, the delay in the implementation of SB 43 in LA County. I am shaking as I speak, but what I say has to be said, because if what happened to me on July 29th of 2023 happened to me, and where the 5150, the words that are supposed to be said, was not followed by the law enforcement, Arcadia PD. And I got chucked to the hospital, and the way he said it to me is, I'm sorry to have to do this to you, but do you know you're being 5150'd? And I was afraid for my life. I can't even walk home safely. It's like, I'm so, like, as a face of the California mental health movement, Each Mind Matters before with Cal Mesa, I feel so betrayed that this happened to me and that the system did not have a psychiatric mobile crisis team.
Thank you, Emily. If you could please wrap up your comment.
Thank you. It's like, how far have we come and how much backwards have we gone? And I would hope that all of our systems could keep our system accountable and in alignment. Do we want a 5150 to be a safe space, and can we as peers have the choice to be taken to a peer respite instead of an LPS conservative site where I would call that expensive adult babysitting service by TV. There were no social workers, hardly any, to the point I facilitated my own support group in there. And the young Asian lady who was my roommate said, "You're the funnest person in here." Thank you. I'm so glad you're here. You know, there needs to be more peer support in the psychiatric system, the psychiatric mobile crisis teams. Where is that push? Thank you for listening.
Emily, thank you for sharing your story, and really your comments drive us to do our job better. So thank you. At this time, we have no more public comments. Is that correct, Kendra? Thank you. Now that public comment has closed, I would entertain a motion that the commission adopts the 2024 through 2027 strategic plan. Thank you. We have a motion. Commissioner Danovich, is there a second?
Second.
Thank you, Commissioners, Vice Chair Alvarez and Commissioner Bunch, for that second. Are there any other comments or questions that commissioners would like to make on this motion? Seeing none online nor in the room. Maureen, I would ask that you please take.
All right. Commissioner Bontrager. Commissioner Brown.
Aye.
Commissioner Bunch. Aye. Commissioner Cannavale.
Aye.
Commissioner Carrillo. Commissioner Chambers. Aye. Commissioner Chen.
Aye.
Commissioner Cortese. Commissioner Danovich. Aye. Commissioner Gordon.
Aye.
Commissioner Mitchell. Commissioner Robinson.
Aye.
Commissioner Roulette.
Yes.
Vice Chair Alvarez.
Aye.
Chair Madrigal Weiss.
Approved.
The motion carries.
Thank you. All right, congratulations. We have our strategic plan approved. Thank you, Norma. Excellent presentation. All right, I am going to now, one moment, please. I would like to invite Miss Tony Navarro, Director of Santa Barbara's Behavior Wellness Department, to come up and share with us some of the great work that's being done here in Santa Barbara. And we are here in your home, so thank you for having us here. So if you could please share some of the great work being done here in Santa Barbara.
Wow, good morning, almost afternoon, Commissioners. So glad to have you here and in literally my hometown. I don't think I've seen many of you since I was Director of Tri-City Mental Health prior to coming home 2 years ago. But this is my home, born and raised, and third generation here, so really glad to have you. And it's a beautiful winter day for us, right? We've got some clouds and some weather going on. So really glad to have you. Hi, Bill, how's it going? So again, sorry for not making the miscommunication and not being here this morning, but as you know, we here in County Land are very busy and we're running from meeting to meeting all day long, really planning ahead, fortifying and ensuring that our system of care is as responsive, accessible, and effective for the residents of Santa Barbara County as possible. I'm happy to have my MHSA team here today, our manager Natalia Rossi, and her support team Nikisha and Faye. This is Faye-Ann Wooten. Everybody know Faye-Ann Wooten? Faye-Ann Wooten is, I have the honor of having Tina Wooten's daughter as a staff member in our MHSA programs here. So there she is. And again, huge asset to the county. She is her mother's daughter and more, and we are really very, very fortunate to have her on our team. So yes, we are doing a lot of great things here in Santa Barbara County. The most important of which is we're doing a lot of evaluating and assessing and pivoting and adjusting our programs to meet the changing needs of our county that have evolved over the last 3.5 years, even beginning ahead of COVID, but certainly since COVID, as we look to all that you are doing, we are in alignment with needing to change those things as well. So we are excited about, I know the last public speaker spoke about a mobile crisis and about co-response, and we are very, very fortunate in our county to have a really robust co-response partnership and team with our local county sheriff, and we do some really great work together there. Our crisis teams are looking to, again, revamp the way we do the work and really changing our name to be crisis and outreach teams, not just in alignment with the mobile crisis benefit, but even ahead of that, understanding that it's the outreach. We know where the folks who are most at risk in our county are on a daily basis. We know that those in the jails need our support after hours here in this county, and so we are working to align our services with the needs of our county. We actually are also really proud of some of our prevention early intervention work that has happened over the last 2 years under the, Natalia's been with us in her role as the MHSA manager for 1.5 years, and since the start of her tenure, we have really fortified and brought along some really tremendous prevention early intervention programs here in the county under her leadership. So I just really want to recognize her and the team for that. One of my favorite programs that we have going on in prevention early intervention is one that we heard from our families who, like others on the call today, talked about really needing to hear the family voice and what was going on for them and how our services needed to better fit their needs. And we hear from families whose loved ones are adults with chronic, severe and persistent mental illness, just the challenges of having those with anosognosia and for whatever reason that resistance and reluctance, that mistrust of a system who's let them down time and time again, that they don't feel like they have a part of the treatment or the care ahead of a case being opened, and that they're calling for support and help, and we spend time with their loved ones and we don't spend time with them. And so this past year we started a new prevention early intervention program, putting it under the partnership of our mental wellness program, who is also the fiscal sponsor of our local NAMI. And we have a program, and I can't remember the name. Peer and Parent Partners in Wellness. And what that team, yes, it's a peer-led team. And what that team does is when we have families who are identifying that they have a loved one that they're trying to get in care or that they just need help with, they go out and they meet with them. They do regular visits to the home, to the family, and talk to them about what their options are. Some of the key goals, of course, are to introduce them to NAMI and engage them in that larger support system, which provides such valuable camaraderie as well as education and assistance to those families. We've heard from many of our families, and in fact the idea gelled with Natalia and I following an interaction with a father who I was visiting a clinic and he happened to walk in as well, and I just introduced myself and said, "How are you doing?" And he said, "Horrible. And I'm here to tell my son's team that he's going to be homeless as of tonight because I can't do this anymore." And so I sat down with him and spent some time. I asked him if he'd heard of NAMI, and he'd never heard of NAMI. And I meet with NAMI myself, and my assistant director meet with them monthly, their leadership, and I had that number in my phone, and I said, "Would you mind if I called him and you could talk to him?" So Tom Franklin answered the phone. He took the call, and they spent 20 minutes on my personal cell phone connecting this gentleman to NAMI. Tom really helping him to see, like, wait, we don't have to make your son homeless. You have options. We can help you navigate the system. And sure enough, that's what happened. And so that's where we got the idea for this program, and we're really proud of that. And that's a new PEI program that we started, and the community has felt responded to in that way. We're doing it currently only in South County, but hope to expand that as we look at the data and look at the results and outcomes of how that's going. I really like your strategic plan. I'm sorry I haven't read it word for word, but when I got here and had time, I was looking through it. I appreciate your support and the leadership of the OAC in helping us to really maintain the prevention and early intervention programs ongoing. They are vital to our system of care, right? I mean, that is the purpose of this act, to get ahead of what we know will happen. There's no way to cure mental illness. This is a thing that will happen to folks, and we need to have systems that are responsive to catch people early in their need and hopefully keep them on track for the lives that they deserve and were meant to have. So glad to have you here in Santa Barbara. Really glad to hear and that you rolled out your strategic plan today in our county, and I hope you guys have a good rest of your meeting. Thank you.
Thank you. Appreciate it. All right. Yes, please, Commissioner Brown.
Before she leaves, I just would like to say thank you, Tony, for coming. And Tony has been really a great partner to us in the Sheriff's Office, and we have this program that she mentioned, the co-response teams, where we have sheriff's deputies and police officers that are teamed up with clinicians from her agency, and we've had lots and lots of meetings and discussions, and some difficult discussions sometimes on some issues, but she's always been there, always bounced back, always come in whenever there's been a problem thrown her way. I'm kind of biased, but I think she and I have the two most difficult organizations in the county system to run, and she's just a great partner, and all of her staff that are here today, I want to thank them as well. And Fan, we are all so proud of you, having known your mom and worked with her so closely, and she had a very special place in our hearts. And I can't tell you how nice it is to see you here and how proud she must be of you looking down. So thank you.
Thanks.
Please, Commissioner Mitchell.
Thank you so much for coming and just sharing your boots on the ground approach. I love hearing that because to me, your peer to partner wellness program, someone came in with the need and you came up with a solution. So, and then to create a whole program from that. So really hats off to you. And just thank you so much for showing that you really get it from an implementation standpoint. And to Tina's daughter, it's so nice to meet you. Your mom and I would talk about our little girls. So what are you, about 24 now? Yep. Same age as my daughter, and we shared many a story about our little girls. So it's really nice to see you, and just I agree with Sheriff Brown. Your mom is so proud of you. So thank you, Santa Barbara County.
Yes, Commissioner Chambers, please.
I just wanted to add, I think Santa Barbara is on the right track relative to how to integrate peers, family members, and individuals with direct lived experience into the service delivery across the continuum of care. I like that you highlighted that as a director of a whole system. I think that should be modeled across the system, and other directors definitely can lend to your knowledge. So I just want to uplift your voice and continue to empower you to utilize this, workforce that's ready, that's boots on the ground. We're trained, and we're ready to meet the workforce shortage and the complex needs of Californians, and particularly of Santa Barbara. I just want to uplift how you're utilizing peers. Thank you.
Okay, so I also want to acknowledge that I loved your mom dearly, and heard about when you were going off to school and what kind of sheets do you get and what do we do, and so heard all about it. And I have a 25-year-old, and so compared pictures and what about connections, and so great times having conversations. So love that you're here, and so thank you. We are going to now take a 30-minute lunch break. We would encourage those online to take a break. We will be back in 30 minutes. So no, we won't.
No?
Sorry, we have
We have 1 hour for lunch, actually, on the agenda. But we can do 30 if you'd like.
Do you see this stunned face? We never have an hour for lunch. We are going to take a 1 hour break for lunch. Go surfing. So we will be back in an hour. See you then. I hope you all had a nice lunch break. We are going to go ahead and move on. The next agenda item is the CRDP Phase 2 evaluation update. We will hear a presentation on the evaluation findings from Phase 2 of the California Reducing Disparities Project by Sylvia Rodriguez, Chief of the Behavioral Health Equity Branch in the Office of Health Equity, Department of Public Health. Dr. Cheryl Grills, Professor of Psychology and Director of the Psychology Applied Research Center, and Dr. Elia de la Cruz Toledo, researcher for the Psychology Applied Research Center at Loyola Marymount University. We had originally planned to hear about these findings at the Cultural and Linguistic Competency Committee in November of 2023. However, due to time limitations, they were not able to present on this important work. This may have turned out for the best, as it is appropriate for the full commission to hear these findings. Our hope for this agenda item is to hear about the lessons learned and how those lessons can inform next steps in advancing community-defined evidence practices around the state. We are grateful that they are here to join us today, so we invite you to go ahead. I'd like to welcome Sylvia, Dr. Grills, and Dr. Toledo to make their update, to share their update.
I will take the opportunity to just introduce them and use this mic if it's okay with all of you.
Please.
Okay, thank you. Good afternoon, buenas tardes. My name is Silvia Rodriguez. Pronouns are her, hers, and ella in Espanol. As the chair pointed out, I serve as manager of the Behavioral Health and Equity branch at the Department of Public Health, and I am the principal administrator of the California Reducing Disparities Project as of October 2022. I, however, stand on the shoulders of many who brought the project from vision to design to implementation and evaluation. Today, you will hear from one of those visionaries who took the ginormous task to evaluate the California Reducing Disparities Project and produced a 400-plus report, which was approved by California Health and Human Services Agency in the spring of 2023. And if you are having a hard time sleeping at night, you can find that report at cultureishealth.org. That is the site dedicated to the California Reducing Disparities Project. It is my pleasure to introduce Dr. Grills and her team. I will save you the time, however, of reviewing their bios. I believe that you have their bios in your packet. And however, when you review the bios, you will agree with me that this is a one-of-a-kind team led by Dr. Grills. I will emphasize and highlight and underline all of the above that Dr. Grills is a world-renowned, known researcher and psychologist. And I also want to say thank you for participating in the reparations task force. I really appreciate that work. Please join me in welcoming Dr. Grills. I and my team, Dr. Liu, who joined us recently, who is the contract manager and also researcher for the Office of Health Equity, and her Jessica, who is one of our contract managers and also was the lead not too long ago in doing contract management for the park team. Without further ado, I will be here to answer any questions that you may have that you can direct as far as Department of Public Health is concerned. However, with regards to the research, the experts are here, so please join me in welcoming Dr. Grills and I call her Dr. Elia. So welcome and take it away. Thank you so much.
Thank you so much, Sylvia. Good afternoon, everyone. Thank you for this opportunity to share findings from the CRDP Phase 2 evaluation. I'd actually like to start with a simple analogy to contextualize the importance of CDEP's culture and context, something I discussed actually on Tuesday in my research methods lecture with my class. So first, if you asked a sample of people to name a movie they enjoyed watching over and over, would answers differ if the sample were 22-year-olds versus 62-year-olds? What if you asked people to name a place they would go after school? Would answers differ if the sample were youth in a high income versus a low income neighborhood? What if you asked people to name a food they would commonly have on special occasions? Would answers differ if the sample were folks in Hawaii versus folks in Maine? Finally, what if you asked folks what mental health meant to them and what healing looks like for them? Would answers differ if the sample were members of the Hmong community, an indigenous community, a Latino community, African American elders, the LGBTQ community? The answer to all of those questions would be yes, there would be differences in answers. And so why do we assume there is a one-size-fits-all model of human behavior, health, illness, and intervention? Why do we not invest more time, energy, and increasing accessibility for culturally and contextually based approaches? Enter community-defined evidence practices, CDEPs. The state of California made that investment, and we are here to share some of those findings. And so why is that report so long? Well, the statewide evaluation was charged with answering 2 objectives that had 7 questions embedded in them. And the first objective was to evaluate the overall CRDP Phase 2 effectiveness in identifying and implementing strategies to reduce mental health disparities. And the second objective was to determine the effectiveness of the CDEPs. So we had a lot of questions to answer because those 7 questions had sub-questions. That's why the report is so long. So we organized these 7 questions, especially for our purposes in the final report, into 3 buckets. The first bucket actually deals with, I can't even see the screen. I'm so sorry. Let me put this on play mode on my laptop so I can see. What was the overall effectiveness of CRDP and its use of CDEPs for preventing and or reducing severity of mental health conditions in its priority populations? Secondly, how cost-effective was the CDEP strategy and what was the return on investment in the initiative? And then third, to what extent were CDEPs validated and were the evaluation frameworks developed and used for the CDEPs? So we're going to address those first 2 questions and only the tip of the iceberg for those first 2 questions today, given time. So that being said, this is a quick overview of and the focus of the statewide evaluation. I'm going to say SWAY from here on out, core measures and the key instruments and areas of assessment. So there were 5 basic categories of data that we utilized. There was the participant survey, which gave us participant level data with a pre and post test. There was organizational level data, semi-structured interviews that we conducted, a review of records, and then secondary data in the form of the medical expenditure panel survey, which we accessed. So the statewide evaluation did not, and I'm going to say this again, particularly for those who are really into doing kind of social science research that's wedded to clinical trials, that's wedded to the demigod of p-values, statistical significance. We did not bend the knee to either one for this evaluation. It was not appropriate. So we did not use a randomized controlled trial experimental design with assignment of CDEPs or their participants into a treatment and control group. Most IPPs, when they did their local evaluations, did not use experimental designs either. Now, why is that the case? If you understand the California Reducing Disparities Project, one of the immediate things that will jump out is the incredible diversity. This initiative was diverse on every possible measure that you could think of, every possible category. And so the interventions were varied in the settings, the types, the length of intervention cycles, the size of the cohorts. The community demographics differed culturally, linguistically, historically, subcultural perspectives, and the context, the historical and contemporary context for those communities. The social and political conditions were different for those communities. And we were dealing with 5 different priority populations. So with such great diversity in populations served and the strategies employed and the specific program designs that were used, a wide array of possibilities existed for IPPs, the implementation priority projects, to do quantitative and qualitative data collection. So there was variation in sample sizes. And because of all of this, comparisons of priority populations was neither appropriate nor valid. So then how did we approach this? The statewide evaluation data analysis plan included multiple frameworks across a spectrum, from traditional to highly innovative. So remember, we had our 2 objectives, and so how did we approach them? We first used a mixed methods parallel combination approach for baseline participant level data and programmatic initiative-wide data. Parallel combination is just a fancy term for saying we use multiple methods, mixed methods, qualitative and quantitative, collected those data simultaneously, analyzed them independently, and then brought them together in what we call triangulation to see if they were saying some of the same things and if they were corroborating each other. In addition to that, we used a Bayesian analysis paradigm that also included statistical best practices to assess the extent to which CRDP Phase 2 delivered results via some credible intervals on what we call effect sizes for the variables that we were interested in. And we used matched pre and post-test participant level data to do some of that. So in a sense, the CRDP evaluation in terms of the statistical analysis is at the cutting edge of where social science is going when it comes to data analytic procedures. Statisticians have been telling us for years in the social sciences, stop it with all the p-values. You're overreaching with it. And Bayesian analyses can offer a lot more. So we switched to a Bayesian analysis. We also use a cost-benefit analysis for the business case to calculate the dollar value of health and non-health savings related to improvements in the CDEPs, the community-defined evidence practices in terms of participants' mental health. Again, using the matched pre- and post-test data as well as the MEPS data. So, what are some of the findings? In terms of that first research question about the effectiveness of CRDP and its use of CDEPs, CRDP participant outcomes support CDEP effectiveness. Essentially, CRDP made mental health services more accessible and improved mental health. Secondly, it's the statistical modeling of CRDP participant outcomes show that positive mental health findings were in fact robust and support the overall efficacy of CDEPs as a mental health prevention early intervention strategy. And then third, the initiative was supported by culturally grounded technical assistance provided to support CDEP's development, implementation, evaluation, and the organizational capacity of the community organizations that designed and implemented those interventions. In terms of the second research question, how cost-effective was the CDEP strategy? CRDP is cost-effective, and I'm not going to take the time now to state what the effectiveness was, what that return on investment was, because my colleague, Dr. De La Cruz Toledo, he is going to go into detail about that. But there was also the question of to what extent were CDEPs validated and what were the evaluation frameworks used. The local evaluations done by each of the 35 organizations had findings that were culturally informed in terms of the outcomes and that used things that extend beyond standard mental health measures. In other words, if we go back to my opening questions, there was no assumption that 20-year-olds and 62-year-olds were going to have the same responses and experiences of their mental health. So let me jump to some information about access to mental health services. So in this section, I'm going to present a snapshot illustrating how CDEPs played a critical role with reducing service inequities for their communities in terms of availability and utilization. We don't have time to get into a discussion of the quality, but you can find that information in the report. So in terms of the key findings, there are three things that we were looking at. How did CDEPs contribute to mental health access? access operationalized as availability, utilization, and quality. Where do CDEPs fall in the prevention, early intervention, mental health spectrum? And what does the data reveal about the mental health status and needs of individuals served by the CDEPs at baseline, at the start of the projects? So in order to explain this, I need to step back for a second. And this was partly inspired by you, Toby, that we went back and we contextualized for you some of the prevention, early intervention spectrum. And so when you look at this slide, what you're going to see here is one way to view an individual's mental health. And it's on a spectrum spanning a continuum from positive, healthy, to stressed and struggling, to being unwell or in crisis. Mental health care services also exist then on a continuum of care to meet the range of individuals' needs. So while funding for mental health promotion, prevention, early intervention, and recovery is often siloed for each strategy, they are in fact interrelated and they're overlapping. That's what's happening on the ground, on the street, right? In people's real life and real lived experiences. So one of the strengths of CRDP is that the CDEPs were not prescribed to be either prevention or your early intervention. These hard and fast boundaries, they sound nice and they make things seem nice and neat, but they don't match reality. So 11 of the CDEPs had a prevention program, 4 CDEPs had an early intervention program, 18 CDEPs had both an early intervention and prevention program. And the CDEPs served who they set out to serve in phase 2. So you can see on the demographic, the profile shows an incredible level of diversity, both for adults and for youth, in terms of age, gender identity, race, and sexual orientation and gender identity. So we also were able to demonstrate that the CDEPs were addressing immigrant and refugee populations as well as limited English proficient populations. So at baseline, at pretest, CDEPs provided services to adults and adolescents who presented with vulnerabilities when they walked through the CDEP door. And in the 12 months prior to receiving CDEPs, nearly 3 in 4 adults had a mental health need, and 1 in 3 had an unmet mental health need. For adolescents, nearly 1 in 2 had a mental health need, and 1 in 3 had an unmet mental health need. So going forward then, one last piece of contextualization is that we use the K6 as the way we operationalize psychological distress. So I want to share just a tidbit of information about that measure. So the Kessler-6, or the K6, is a brief screening tool that it's a brief screening scale for nonspecific psychological distress in adults, and it's been shown to be highly predictive of adult serious mental illness. It is not a diagnosis. This is just indicating psychological distress. In clinical studies, the validation studies, K6 scores of 13 to 24 indicate probable serious mental illness, while 0 to 12, it's probable that there is no serious mental illness. The K6 scores, they can be equal to or greater than 13 in the general population, but the ranges can go from 3.4% to 6% in the US. And what we found in California was that it was 8.5% in the study that was done by Grant and colleagues. So, what did we find? We found that among the CRD sample of adults and adolescents served by CDEPs, over 1 in 4 were experiencing low psychological distress, 1 in 3 were experiencing moderate psychological distress, and over 1 in 3 were experiencing serious psychological distress. For our adolescents, over 1 in 3 were experiencing low, 1 in 3 moderate, and 1 in 4 serious psychological distress. And so at the end of the day, these findings demonstrate the importance of allowing CDEPs to provide services on a continuum of care, especially since we know that prevention, early intervention, and treatment can and do overlap in the margins. Now, according to the National Institute of Mental Health, in 2023, it's estimated that more than 1 in 5 U.S. adults will live with a mental illness. Nearly half of these individuals received mental health services in the past year, and nearly 1 in 2 of adolescents had any mental disorder. For those who seek and receive mental health treatment, about 1 in 2 meet criteria for a past year mental health disorder, and an additional 13% for other indicators of need. So what does this show us? The adult and adolescent graphs of the K6 scores show the differences in psychological distress between them, right? The takeaway is that adolescents came in the door with lower levels of distress. And in the mental health improvement portion of our presentation, I'll talk about, I'll mention those differences. We actually ended up taking out the adolescent findings because of time here today. So while we don't have enough information to distinguish mental health problems or illness for those who have serious and even moderate distress, the data suggests CDEPs are serving individuals who are unserved and underserved and in real need of help and support. The other thing that I want to mention here is that in terms of the mental health access and outcome, CDEPs provided a diverse range of services and activities, interventions, and even treatment for individuals and their families. 6 strategies were used, and then across the CDEPs, a constellation of different groups of individuals were served. So to round out my portion before I turn it over to Elia, I want to say something about mental health improvements. In particular, did CDEPs promote the development of mental illness and or promote positive well-being? And did CDEPs reduce the mental health risks for people with early signs of mental illness? So what we had were 5 kind of major core measures, outcome measures. 3 of them designed by Park, 2 of them looking at cultural protective factors, and a 3rd one, social isolation and risk. And then 2 widely used measures, the Sheehan Disability Scale, and as I mentioned before, the K6. So let's see what we found. One of the biggest drivers of the amount of change or improvement is what level of distress people were at the start of their involvement with the CDEP, right? And so here you're looking at an individual or a group of folks who started somewhere around moderate distress, measured by the K6 as a score of around 10.5. And then what happens is they got intervention, and they moved 3 points lower in their distress at post-test. Here we have a person who's at moderate distress, but the level is lower on the moderate scale, starting at about 7.5. And then at the end of the CDEP, on average, a decrease of 2 points in their distress scores. Now here we have an individual at the high or the mid-level range of severe distress, coming in with a K6 score of about 14. By the end of their intervention, their scores decreased to a score of 8.6, almost 5.5 points difference. This is a pretty significant jump. What we found was that the worse off you were at pre-intervention, the greater the margin of improvement, the less distressed people were after the intervention. And this trend was found consistently across age groups and across priority population hubs. So again, as a reminder though, this is psychological distress. This is not a measure of mental illness. But at the end of the day, adults who reported the highest levels of distress at pre-intervention had the greatest decreases in their distress at post-intervention. And then finally, for folks who started out with low levels of distress, and here again, we're still talking about adults, with a K6 score of about 4, did they move down, up, or stay the same? They kind of held their own, right? Those who reported the lowest levels of distress, pre-intervention essentially remained the same or showed only a slight increase. This is normal and actually should not be viewed as a negative. In fact, one could argue that this is an indication of a win for prevention because those folks did not get dramatically worse. And there's not much more downward slope you could go, particularly in today's social and cultural, political, and economic reality. And we're talking about communities of color and communities that are marginalized, which means they are under constant and immense racial and socioeconomic stress. So to wrap it up, my last slide, this is a way that we're depicting the findings from the Bayesian analysis. I know, it's like, oh my God, what in the world is this slide trying to show me? It's actually quite simple. And I don't have time to break all of it down, but let me say for the moment that this slide shows the effect of CDEPs considering the characteristics of the participants and even the context they were living in, including the entrance of COVID-19. And we essentially started with the kind of assumption that CDEPs had no effect. And so to do that, we entered in, if you look at that green box on the left, we entered in everything but the kitchen sink to try to see if it would account for, you know, and take away any of the effect of the CDEPs. Well, the kitchen sink, we threw it out there, and what did it show us? It showed us, even in the context of all of these other variables, CDEPs were making a difference. Okay, and that thing that's circled there is demonstrating the 3-point improvement in psychological distress, which is a big deal. It means that not only that participants had better mental health, but that they had some health-related cost savings, as you'll see in the business case. I'll just mention that for the adolescents, the picture was essentially the same. It didn't matter what hub you were in, what kind of CDEP you got, what was going on in terms of sexual orientation and gender identity, what service model was being used, or COVID, adolescents and adults showed improvement. The adolescents, though, if you remember from earlier slides, their level of distress was not as high as the adults, and so the level of improvement was not as robust as the adults. Also, the sample size for the adolescents needs to be a little bit larger if we want to start seeing greater effect sizes and greater improvement. So that's to be determined with more data collection in the phase 2 extension. So now I will turn it over to Dr.
Before you turn it over, can I ask you a quick question? I was just curious about the focus on psychological distress only, as opposed to using like the K6 in conjunction with the BDI and BAI.
Because then not all CDEPs were looking at depression or anxiety. You know, it was quite diverse. And so we wanted to kind of get something that was a more generic indicator of psychological how do I say it, psychological well-being versus distress. And the K6, when we looked at tools that could do that, the K6 was one of the most widely used and found to be valid and reliable across different populations and correlated with measures like the BDI, et cetera.
Thank you.
Here you go, Elia.
Okay, so for the last portion of the evaluation, I'm going to talk about the business case, which is the cost-benefit analysis of CRDP Phase 2. And the reason why it goes at the end is because it builds on all of the other things that Dr. Gross has mentioned. It builds on the number of people served, it builds on the improvements in mental health, and so we used all of those pieces to build the cost-benefit analysis. And so rather than focusing on what does all of this cost, we focused on how much does all of this save. And so what we're trying to answer here is not only that, but also what matters most, prevention or early intervention. And I think Dr. Grills already prepped you on that, which is both. And as a very brief overview of cost-benefit analysis, this type of tool is a systematic process for identifying, quantifying, and comparing expected benefits and costs of an action, investment, or policy. It's widely used across a lot of agencies in the US and across the world. And CRDP's cost-benefit analysis includes health and non-health outcomes. Some of the advantages of CRDP's cost-benefit analysis are that it measures CDEP-related social benefits. It provides a useful benchmark from which to evaluate and compare potential PI investments, and is used to calculate CRDP's return on investment. So broadly, the steps that we follow to calculate this cost-benefit analysis start here, and then point number one is that we define the framework for analysis, which means that there's different points of view from which cost benefits can be done, and we chose the society's point of view, which takes into account the direct costs and benefits for CDEP participants, plus the indirect costs and benefits for non-participants, as mainly in the roles as taxpayers, so the global is the benefit to the society. Then we identified costs and benefits, and I will specify this in the next slide. Then the third one is defining a time horizon using the average amount of time participants spend on a CDEP per hub and per implementation pilot project, so to include all of the diversity of these projects. Then we model the benefits, and I'm going to show you one example of how we model these benefits. Then we calculated the costs and benefits, including everything from financial, economic, and health costs. And then finally, we tallied the total value and compared costs and benefits that accrued over time. And so in terms of costs, we included IPP program costs. We included CRDP operating costs, which included the money spent on technical assistance provision, the statewide evaluation, and other type of ancillary contractors. And then we also included CDEP participant costs, so we calculated things like the participants' travel costs and then the participants' reduction in leisure, because in economic modeling, one always thinks of what other activity can a person be doing instead of what they're doing right now, and that's what the cost of that activity is, which is they could have been doing something leisurely. Then on the benefit side, we included health expenses averted. That includes things that from improvements in mental health, there's an expectation that there will be lower health bills, fewer hospital visits, and less money spent on prescription medication. We also calculated productivity and income gains, which are related to how improvements in mental health are also related to fewer days missed at work, more hours work, and better job continuity. And there's a large literature in economics that also supports this pathway. Then we calculated out-of-program income gains that are related to job-related benefits that accrue even post-CDEP participation. And then lastly, there are some non-monetary benefits that we didn't include in this cost-benefit analysis as they were data limitations, but we conducted a robust literature review where there is a lot of, there are several findings that point out that improvements in mental health are related to lower suicidality rates, reduced recidivism, and cultural connectedness. So usually in cost-benefit analysis, when you have non-monetary benefits, you only add a plus to know these benefits could have been even higher if we were able to monetize all of these non-monetary benefits. And then before I move on to the results, I also want to tell you about the data sources that we used. In terms of costs, we use data from the Office of Health Equity in terms of the budget for all of these costs. And then for the CETA participant costs that we calculated, we used the IPP local evaluation reports and the semi-annual reports. In terms of benefits, we used the SWAY participant questionnaire that we designed. However, in this questionnaire, we did not include data, or we did not collect data on health expenditures. And so for that reason, we also used secondary data from the National Medical Expenditure Panel data, which is a large-scale data set collected in the US, and it's the only one that contains individual level data on how much people spend on health expenditures. Now, this is not a perfect data, and there was a restricted version that we needed to access to get stuff related to, for instance, since we have a hub that is focusing on LGBTQ participants, we wanted to have information on sexual orientation, and the MEPS data doesn't have that. And so we requested a link to the NHIS, which is the National Health Interview Survey data. And to do that, I had to go through a very lengthy process to get certified to use this restricted use data. So I got FBI clearance, and I hold a special sworn status by the Census Bureau so that I am able to conduct this analysis and further all of this data analysis. And so, as I mentioned, this data isn't perfect, but it's the only available data that we could use. And so the national data is publicly available, but the restricted version includes California, so we requested that data. And again, the MEPS does not include information on sexual orientation or gender identity, so we requested that link to the NHIS. And even though we did have access to sexual orientation, it's not as disaggregated as the data that we collected through our own questionnaires. In addition, I think one of the questions from Commissioner Bunch was, why did we choose K6? K6 data was luckily in this MEPS data, so we were able to link changes in the K6 score to changes in the expenditure on healthcare. And so, however, this data is only available on people 18 years or older. Then the other limitation is that in the MEPS data, there are small samples for both Asian American and Native Americans. But again, this is the best data that we could have gotten, and so we just want to let you know that there were limitations. Now, in terms of the context, before we jump into understanding what's the return on investment for the CRDP, I want to put you in context using data from the National Academies of Science, Engineering, and Medicine that found that for every dollar invested in PEI, society saves between $2 and $10 in healthcare costs, criminal justice expenses, and by avoiding lost productivity. Now, if we include prevention programs related to early childcare, that return on investment goes up to $13. So the question is, where does the CRDP return on investment stand? And that's what I'm going to show you in the next slides. So up to now, we don't know what's the relationship between, we can anticipate, but we don't know what's the relationship between psychological distress and healthcare expenditures. But this is modeling of the MEPS data that shows that for the different races and ethnicities, there seems to be a positive relationship between the more psychological stress you experience, the higher are your predicted out-of-pocket health expenditures. And this is true for all of the different races and ethnicity that are shown in this graph. And so this positive relationship between the MEPS K6 scores and the out-of-pocket health expenditures are already proven and confirmed in other literature. Other researchers have shown that this is true, that the more stressed you are, the more you tend to spend on health expenditures. And so going back to that figure that Dr. Gross showed on that three-point improvement in psychological distress, we want to know, well, what does a 3-point improvement in the K6 mean in terms of dollars? And so before I jump into that, I want to show you a snapshot of one of the health regressions modelings that we use, in which we include, so we have health expenditures on the left-hand side because we want to know how health expenditures change based on your psychological distress, which will be the continuum of the K6 score, your race and ethnicity, and the interaction between the K6 score and your race ethnicity, as well as controlling for things like sex at birth, English language fluency, US-born status, health insurance status, household income, education, and age. And so what we focus in our modeling is this interaction between the race ethnicities and the changes in the K6, so we can tell for every 1-point increase or decrease in the K6 scale, how are health expenditures changing and how does that differ by race and ethnicity. And so in this table here that I took from the modeling, I just anonymized the hubs so that there's a generic hub A, B, C, and D. And you can see that if you go, I mean, it's backwards, but if you go from bottom to top, because bottom to top means that your psychological distress is improving, you go from, and you see a 3-point drop in psychological distress for a person in, let's say, hub A, you go from a K6 score of 11 to 8, which means that you're still in the moderate distress area. And that means that your yearly health expenditures are expected to go down from $1,400 to $1,300, more or less. And so that means that there's around $130 in savings for a CDEP participant in this Hub A who experienced a decrease in 3 points. And so that's how we calculated health savings that are related to lower psychological distress. So this is related to prevention and early intervention. We also calculated health savings related to lower impairment for those with severe distress, which is related to early intervention. And so we also calculated productivity gains, which is related to avoiding productivity loss from better mental health. And this is what I'm going to show you here. So after we calculated those gains, we also calculated lifetime CDEP benefits, which is how increased earnings from sustained mental health improvements are valued. And so what this means is that we calculated the expected discounted value of improved lifetime earnings. And so, for example, that person from Hub A, which had an estimated average gain in earnings related to better mental health, are around $1,800 for an adult participant. And so if we also think about how a typical worker has an estimated retirement age of 65 years of age, so the average age of participants in this particular Hub A is 37 years of age, then it's so small I can't see it over there. But the calculated long-term annual gains for 28 years, we used all of this to calculate that. And there is a question of whether an improvement from participating in a CDEP program could be sustained in the long term, and we don't know if this is going to happen specifically in 3-point gains for the entire time, but we do think, because this is an average, and we see that people had gains of 6 or 7 points, some people had gains of 1, that on average this could be sustained because these people are getting the tools to get an improvement in their mental health, and then also the availability of the community and other things that are available to them even after they leave the CDEP. And so once we add all of this up, we have the health savings for a particular hub. And so we have that multiplied by the number of participants for that hub. And so we add up all of that for all of the hubs, and then we have the CRDP wide health savings. Then we do a similar process for productivity gains, where we have the productivity gains by the number of participants for people that worked, and then we added all of that through the hubs. And then we had the CRDP-wide lifetime benefits. And once we added all of that up, we had an estimated benefit of $559 million in estimated benefits, and an estimated direct and indirect cost of $105 million, for a total of a present discounted value of current and future benefits for the society of around 400 and, I'm sorry, I can see the bottom of that, 454, and I should know this by heart. So what it means is that we also use that to calculate the return on investment, which is the difference between benefits and costs divided by the cost. And so the CRDP return on investment is between 4 and 5, which means that for every dollar spent, CRDP is expected to deliver between $4 and $5 in long-term, current and future long-term cost savings. So the savings, again, are related to better mental health experienced by CDEP participants, fewer health-related costs, and fewer days missed at work during and after CDEP participation. And so we also, in the report, included a sensitivity analysis, which also looked at including youth in the costs and benefits, and we also showed that the benefits are higher, but the return on investment remains the same. And so going back to that figure that I showed you at the beginning of this portion of the business case, where we see that the average return on investment for PEI programs is between 2 and 10, we see, or between 2 and 13 if we include early education, we see that CRDP's return on investment is right in the middle. And so, again, we didn't monetize things related to the criminal justice systems and other things, so this could potentially be higher. And luckily, we have a phase 2 extension where we're gonna try to do more things to make this analysis more robust. Thank you.
And I'll also just add that we just confirmed the people who will be part of an advisory body, specifically on the business case, so that we have the benefit of the best minds in the country to contribute to the design and analysis of that data. And that's it. Thank you. Questions? Oh, no questions. Good. We'll see you all next time. Right.
I guess for me, it's like, Chair. For me, is what is next steps? Like, what do we need to do? Just in layman's terms. Maybe you said that and I missed it, but.
Yeah, no, we implied it.
Oh, okay, yeah.
So I would say two, right off the top of my head, next steps are, one, to really take into consideration in your deliberations moving forward on anything related to mental health in the state of California, the potential role of CDEPs as a bona fide, credible approach. And then in addition to that, in our final report, and in the executive summary of the final report, we make 5 recommendations that we would really like you to take into consideration. And they have to do with things like, part of the challenge, for example, with the cost-benefit analysis was, our state and the country has done a pretty poor job of collecting data, mental health data and other data, at the level of specific ethnic and subculture groups. So, and there's been a tendency to lump certain racial groups into one large category, which makes absolutely no sense. And in fact, it can be harmful because it can obscure important differences. For example, within the Asian American, Native Hawaiian, Pacific Islander American communities, vast diversity there. And so when we want, and our communities for the CDEPs were in fact extremely diverse. And so for some of those communities, when we go to look at the national data or the statewide data, it's not available at the level of those specific communities, so we're handicapped. Another example would be to use capacity building approaches, or include capacity building for the community-based organizations that are offering CDEPs. There's no wanting of wisdom and strategies and understanding about mental health and mental health promotion. What there may be challenges with, not for all, just for some, is the ability to meet the litmus test of funders, whether that's the state, the city, the county, you know, or the feds. And, you know, that essentially then cuts them out.
Exactly.
And then our communities pay the price.
Have you seen any CDEPs used on a county level by any of the directly operated programs throughout the state?
They're not necessarily called CDEPs, and I don't know, and maybe CDPH would know this better than we would, if a county has, you know, taken this on full-heartedly. But what we can say is that, for example, in LA County, there is an initiative called Ready to Rise. They don't call themselves CDEPs, but they started out with 49 communities in LA County who were charged with designing and implementing positive youth development programs to decrease the exposure of youth of color in particular, and all youth, in entering into the juvenile justice system. The approaches that they used, I can't even remember. I wish I had some of the other team members here with me. I can't remember if even 10% of them used evidence-based practices. Youth weren't responding to them, you know, but they did design very culturally based, very critical consciousness based, positive youth development emphasized interventions that the youth did respond to. And so they would be an example of CDEPs, but they're not called that officially.
Just one more thing. So for my language, the language that I use in advocacy, I mean, should we be saying like this should just be like a standard practice? Like when you're serving, you know, particularly, you know, disenfranchised groups, like we need to be having CDEPs in all, like as across the board in our intervention. Like,
I would say that we need to make sure communities have the option.
Okay.
To have access to CDEPs, as well as the promotion of EBPs, evidence-based practices, right? I think that it's really not very even. Right now, it's like, you only get funded if you do EBPs.
Yes.
You only recognize if you do EBPs, right?
Yeah, you're right.
And the community's response to the EBPs,
yeah, particularly like
they're not
the communities we talk about, yeah.
Right.
Awesome, I appreciate that wisdom.
I'd just like to make a comment.
Yes, please.
So thank
Commissioner
you, Dr. Grill and your team, just for coming forward with your presentation on CDEPs and just showing the instruments that you use to solidify your outcomes of the study. I just totally applaud you. The only reason I understood it is because I just listened to my daughter do her dissertation, so I was halfway following you. So I think it's great. So thank you so much for this eloquent presentation of the use of your instruments and how you arrived at your recommendations. So I think it's brilliant work.
Thank you.
Thank you.
Yes, please, Commissioner Rolette.
The organization that I'm privileged to be a leader of is Turning Point in Sacramento. And for a long time, we've been involved with, through a long time, 3 or 4 years, with this group called the Confess Project. That's Black barbers and beauticians that are trained in mental health first aid, which is on the sort of evidence-based practice side, and doesn't always translate well into reducing stigma for people in the Black community, but going to the barber shop and the beauty shop is. And they are doing what you described. They are recognizing that how a person presents in the barber shop and the beauty shop says an awful lot about their emotional and mental health and well-being. And helping the barber or the beautician recognize, or the barista, recognize how that person is presenting, and how that person is able to accept unconditionally overtures of help from those individuals, because as one barber said to me years ago, and you can understand why I said years ago, when you sit in my chair, I'm like a counselor for you. You trust me. And that project has taught me a lot about, they know how to provide access to people, and then do the more important thing, get feedback regarding their experience, because they go back to the barbershop. It's the same place they go back to, and they ask them, how was your experience when you went to get support around behavioral health and mental health? And if that's not a community-defined evidence-based practice, and partnering with them, because they tell us, this is how we want you to present your mental health services to our community, so our community will accept them. Thank you very much for what you're doing.
Thank you. You're absolutely right. The barbershops and the hair salons are crucial, as are the churches. Yeah.
Thank you. Commissioner Carnevale, and then Vice Chair Olivares, please.
Thank you, Madam Chair. First of all, I want to congratulate you on doing an ROI analysis. We don't get a lot of that, and you're speaking my language as a business representative. Having said that, then, one of the challenges of ROIs are looking at what you've measured and the size, because sometimes you get a pilot project and it looks good, but when you scale it, it's not as attractive, or sometimes it's more attractive. It just depends. I'm not sure I'm not sure how to ask this, but I'm not sure I have a sense of how much of this is a pilot versus already at scale. How big are these CDEPs, and what percentage of the problem or population are they currently addressing? Or said differently, if this works, how much bigger does it need to be than it already is? I don't have a good sense of that.
So I'll start with a portion of this, and CDPH, Sylvia, you might want to weigh in as well. The scale, we didn't have a chance to present some of the process data, but we're talking about 15,000 folks, for example, getting referrals. We're talking about, and I was trying to pull up the numbers.
I have the numbers in my head if you want me.
Yes.
So about 15,000 people were served, and this is a subsample was taking the questionnaire, and we used that information, but around 15,000 were served. And then also 17,000 people got referrals, but people could have multiple referrals. So in total, 21,000 plus referrals were provided to people during the span of the program. And so something that we weren't able to show is the diversity of those referrals. So people were getting referrals related to mental health, but also housing, all these different areas.
The social determinants of health.
Social determinants of health. And so I think that your question is really well taken, because this is just the tip of the iceberg. This is just 15,000 people that were served with this 63 million budget, which, if you think of how it was 35 organizations, so for how many years they were running it, it really isn't that much that they were getting, and they were putting out all of these programs and benefits, and some of the organizations were long-standing and serving communities for 30 plus years. Some of them were fairly new, but they became the go-to place where people were saying, I have this issue, and maybe the organization doesn't have the services there, but they would refer them to, and that would improve their health by a lot.
And so in phase 2, we're continuing to examine and collect data to see what's the staying power of what we originally found, as 34 of the 35 community organizations kind of hone in on sustainability of what they've developed and scalability, scaling up and scaling out. And then right now, CDPH has been leading the charge under the leadership of the CDEP organizations themselves to frame and design the phase 3. Like, what does that look like? Should it include those same groups, digging even deeper? Should it expand to more groups? What kind of, and what groups, if it's expanded, should be included, et cetera. So this is the beginning. I think a solid foundation has been laid, and there are many, many questions that still need to be answered.
So it certainly sounds like it's more than a little pilot. It would be
Oh,
a
yes,
pretty big
more,
pilot.
yeah.
But yet the population is a lot bigger. At full scale would be a lot bigger than what we're talking about.
Exactly.
Yeah, okay, thank you.
Vice Chair.
I think Sylvia wants to say something.
Yeah, thank you. The original set of funding was $60 million. That funding sunsetted April 2022. The legislature, through the advocacy of the initiative, the entire initiative, the 35 community-based organizations there responded by providing us an additional $63 million, 58.1 for the provision of the CDAPs. That funding is sunsetting June 30th, 2026. We are currently in the planning and design of phase 3. And I don't believe we mentioned this when we started, but what makes the California Reducing Disparities Project different and unique, it's two things. The first one is the community-defined evidence-based practices, but the second one, it's that it's not top-down driven. We use what is called community participatory action as a way of making decisions. And so, given fidelity to that modality, we started engaging all of the 35 community-based organizations in May. We went on the road in the fall asking Californians what should be the vision of the California Reducing Disparities Project beyond 6/30/2026, knowing that after June 2026, we will not have the funding. And so I anticipate, as a matter of next steps, and let me just also say that we installed a task force composed of 14, 15 members that will look, the goal is for these members to look at the original design of the California Reducing Disparities Project, look at what worked, didn't work, analyze the feedback that we received during the fall, and look into the future, as Dr. Grills say, to let us know should we scale down, scale up, scale sideways, and should we keep the current focus, add focus, what should be that vision? That would help the decision makers at California Department of Public Health and the Office of Health Equity to really decide and seek additional funding if such funding will be available at the time. Currently, that is the process that we are following in order for us to have the vision. And we anticipate having that vision maybe in the summer of 2025. With regards to the current evaluation, Dr. Grills one more time took the task, to renew the design of evaluating that extension that came effective July 1st, 2023, right? And we are gonna have 15 months, Dr. Grill, of data that will provide us a new report that we will make available once agency approves. However, what you can anticipate is that cost and benefit analysis to have some, I don't know what the word used earlier, some reinforcement, or the Better Minds economists to really give us the reassurance that when we say California Reducing Disparities Project and community-defined evidence-based practices saves money, that we can confidently say that. And we are expected to stand that, I don't want to call it advisory committee, we call it, what did we call
Consultatory
it?
body.
Consultatory body. Consultatory, that's like not good for someone as an English as a second language. Consultatory body in April. Oh, March of this year. So that they can work side by side with Dr. Grills, look at the design, look at Dr. Elia's awesome work, and then serve as potential reinforcement so that we can accurately provide that narrative to the decision makers. So with that, I'll stand here in case you have any more questions for Department of Public Health as far as the next steps for the California Reducing Disparities Project.
I have some comments and questions. I don't know to whom. Thank you, and I'm sorry that I wasn't here for the presentation, but I feel fortunate to know a bit more than I think some of my fellow commissioners about the work, and I did review the content, and I do have a couple of questions, and it builds on the conversation that Commissioner Chambers and Bunch and Rolette were having around this idea of approaches that CDEPs apply that I think have really been elevated these last couple of years as the state seeks to reform Medi-Cal and seeks to reform our healthcare delivery system in order to be more equitable. And I say that because we often think about CDEPs as this like separate approach. And while yes, there's 35 programs, I think the elements that CDEPs deploy can be applicable to other parts of our healthcare system, whether it's mental health or, I mean, you name it, diabetes, I mean, you name it, right? There are certain approaches that I think this commission, as part of our strategic plan to create a more equitable mental health delivery system, can help solidify in its evidence, right? Like, when does something become community informed to evidence-based? And how do we as a commission have a responsibility to support that pathway? Because I think it's happening right in front of us, right? So absolutely the CRDP is one, but some of the CYBHI initiatives are funding CDEPs. And it actually should be applauded that these are programs that are getting uplifted and are seeing real results that I think other components of our healthcare system can adopt and take to scale. This idea that these don't have to be separate initiatives, but should be integrated into our reformed Medi-Cal program, our improved care delivery, our more equitable healthcare system. And I get excited to think about our strategic plan and our responsibility as a commission to hold us to taking those programs to scale. And that wouldn't be possible without the return on investment, without the story that you are helping tell. And I just really want to commend you all for that research, that detailed analysis that I think helps make the evidence that much more real for folks that may not live day to day in this program work.
Thank you so much. So yes, bravo for acknowledging that. I did say that one of the things that make California Reducing Disparities Project unique is that we use participatory action, right? And all of that you just mentioned would not have been possible if it was not because the initiative adopted what we call the 3 S's as part of the CRDP extension and the funding that came along with that. So the 3 S's stands for scalability, sustainability, and systems transformation. Part of systems transformation is to really educate the other systems that have cross-sectionality with behavioral health and educating them about community-defined evidence-based practices. But not just education. What we want to do as part of systems transformation is not just to recognize that this works, but also to change the system to compensate for these services, right? And so yes, you have seen that the Children and Youth Behavioral Health Initiative is paying or funding these initiatives. And that came, and I do want to give credit to the initiative because they were there. They held a lot of meetings. They were standing at the microphone saying, why are you not funding this? Another area that I think falls under systems transformation is that prior to the California Reducing Disparities Project, very little was given attention to entering into contracts directly from the state to community-based organizations, because generally the funding flows from the state to the county. So again, systems transformation, right? As part of the Children and Youth Behavioral Health Initiative that OHE is leading, and that's the campaigns, we used the model for the initiatives, for the campaigns to reduce stigma, increase the need for services. So we are using the model of the California Reducing Disparities Project, and we are contracting directly with community-based organizations. So yes, systems transformation, yes, funding the intersectionalities of the other systems that intersect with behavioral health. And Dr. Grills, do you have anything else to say?
No, you summed it up well.
I have one thing that came to mind, which is these organizations are serving the underserved or the inappropriately served. And so when we had that question in the questionnaire about who are they seeking help from, we modified the question that the California Health Interview Survey has, which only provides two options: primary care physician or mental health physician. And so we included traditional physician, traditional helper and community worker. And so a significant portion of people that are coming to CDIPS are being served by the non-Western options. And so when you think of the demand exceeding the supply in the mental health area or in healthcare in general, I don't know how it is for you, but when I try to get an appointment for my child with a physician, they tell me it's a month from now, or 4 weeks, 5 weeks from now, because there's not enough physicians helping, and maybe the issue isn't as critical, and maybe somebody else could help. And so I think in this sense, the CDEPs are filling a void in the very stressed healthcare system that we have.
I have a personal story to tell. I see myself as I navigate systems. I'm very savvy at that. So I thought. 2 days right before Christmas, my daughter's home burned and everything in it burned, right? And I'm like, I can do this to help her. Let's get her some housing, right? Knocked on this door. It was a government door. Shut. Knocked on this door. Shut. Knocked on this door. Shut. A month later, my daughter, her 2 kids' husband, are still displaced. And so I thought, wow, what if we had a community-defined evidence-based to help people navigate this? That would be so awesome. Because a month later, she's still displaced. So it's not just behavioral health where this could work. Commissioner Alvarez, I think this is the model that could potentially work for other systems as well.
So this is interesting conversation to me. It intersects multiple other opportunities potentially as you think about, additional phases in the development. To me, we know that the system, we spend a lot of money in the system because we are not involved in the prevention and the early interventions for precisely these populations. And so this work is great. What could make it even better, we had a site visit last year to UCSF Neurology. If you look at the new neuroscience of the brain, and if we were able to take this the next level and actually measure what's going on in the brain, that gives us root cause evidence as to how it's working and what's working better than not. It gives you greater precision and it gives you greater efficacy that puts, I think, more weight behind the importance of these programs. And the additional thought, we're looking now at some other programs. The governor is very concerned about the huge gap we see in private sector funding of new innovations that do not make their way into the public sector for sometimes more than a decade. This is another great example, understanding what interventions can work, looking at new interventions that are out there, and I personally see a lot of these that are non-invasive or minimally invasive. We live in a world where if something affected our heart, we would be dealing with it immediately, but we have this mental health thing that we don't really understand well, so we just kind of don't do a lot about it, and we pay the price for it later, and now we're trying to do a lot about it. So I think factoring those aspects that this commission is starting to look at more and more into this program gets to the root cause of everything that we're looking at, that we're funding in the end of the day here. So just a comment.
Thank you, Commissioner Carnevale. So at this time, I would like to thank Dr. Grills, Dr. Elia de la Cruz Toledo, sorry for leaving that out before, and Ms. Sylvia Rodriguez for being here. We talked about the projects that you provided the research on and the 35 organizations, and I know for years working at my county, in San Diego County, that County Behavioral Health has funded projects that we're not even looking into the individual counties and what they have funded, and I know there's success stories there. I particularly am very interested in CDEPs with our adolescents, with our youth. What's working? Because I know it's happening, and now that there's such a great demand, what could that really look like? And what can we replicate across our state? As we see our youth mental health issues increase, how can we learn and really replicate? So we need to keep moving this forward. So thank you for being here today, sharing the story. Thank you for being here. We appreciate this, and the commission will continue to monitor what's going on, promote this cause, continue these conversations, and thank you both, Vice Chair Alvarez, for also moving this conversation forward. So thank you, everyone. We are going to move on to public comment. So at this time, members of the public may request to make a public comment on this agenda item by clicking the raise hand button on your computer or the app, or if calling in by phone, pressing *9. Are there any public comments? Please raise your hand now, as the queue will be closing. So, Kendra.
Okay, we're going to start with two that are in the room. We'll start with Diego.
Good afternoon, commissioners. My name is Diego Bravo. Oh, thanks, Stacy. No toots all for that. Thank you. All good. My name is Diego Bravo, and I'm with Safe Passages. We're an Oakland-based nonprofit and member of the California Reducing Disparities Project. Like a few others here, I wanted to just thank the LMU team and the OHE team for coming and presenting, and also thank the commission for just holding the space. I also wanted to highlight just the content of the presentation, the report, and just the power that community-defined practices have. Oh, they're telling me? Okay, is that better? in reducing mental health disparities in communities and for people that for so long have just been under or inappropriately served. This power in practice is fueled by the acceptance that diverse approaches to behavioral health, inclusion and leadership of community voice, and cultural understanding are things that work in mental health practice, and that don't just deserve, but that require a seat at the table if we want an equitable mental health ecosystem in California that actually works for everyone. So given how undeniably valuable the report is, I really hope that after today, the content and the data of the report is utilized in funding decisions and RFP development through the MHSOAC and in developing new guidelines for the commission, including the appointment of the new commission members by appointing others who are well-versed and just really understand the importance and perspective of community-defined evidence practices. We'd be ensuring that the findings of the report and the work of all these communities is not lost on us, effectively just sustaining the programs that have been time and time again proven to be extremely effective at reducing mental health disparities in the state. So I'll cut it short there, but thank you for your time today. I look forward to the rest of the meeting.
Thank you, Diego.
Next, we have Stacy.
Hi, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. Thank you again. You can see why I wanted the full commission to hear this report. This report, frankly, verifies what I think community providers, consumers, and families from underserved communities knew in their hearts, that these approaches and these types of programs work. And now you've got empirical, impartial, robust evaluation that says that it does. I was very happy that your staff put the 5 recommendations that Cheryl mentioned into your packet, so if you want to always have those handy, they're right there. But the commission can go farther, as Diego was mentioning. You can keep the results and keep the effectiveness of CDEPs in mind when you develop and release your RFPs and RFAs. I'm talking about you, the commission. Rules and regulations that you are in charge of, please keep this in mind. Particularly if Proposition 1 passes, you, the commission, will be in charge of $20 million per year in innovations. And when you roll out the new rules and regulations for that program and you make those awards, please, CDEPs are just totally appropriate and probably should be set aside, at least some minimum amounts for that. And then on your committees, when you appoint people or you form committees for any project, you should have people who are familiar with CDEPs on these committees so that they can incorporate. Because even though, as Commissioner Alvarez talked about Medi-Cal funding, for example, which we
Thank you,
would
Stacy.
love.
Your 2 minutes are up. Please wrap up your comment.
Okay, I was just going to say that it's not always just simple to just say, oh, well, we should fund it with Medi-Cal, because Medi-Cal has many regulations and rules that are frankly prohibitive for some, not all, but many of the organizations that operate these CDEPs. So it's not simple. But thank you again.
Thank you, Stacy.
Okay, we'll move to online public comment and start with Richard Gallo.
Hello, can you hear me?
We can, Richard.
Good afternoon, commissioners and staff. I would like to thank the panelists for their expertise on this. I truly believe that the commission has a duty to follow their recommendations, but also to include not just the $20 million annual funding, but with all funding sources that the commission is issuing to with the counties to include additional reporting requirements. I think you should, I think you can, and I think it would be more reflective in analyzing the impact, the usage of the dollars that are being spent with these funds that the commission is dispensing to the counties. We also need to look at dual diagnosis, mental health, and intellectual disabilities because families are impacted by this, especially on the mental health side with the lack of resources, treatment, and services for child and adult with intellectual disabilities and mental health because the regional center system only focus on area of intellectual disabilities. You also need to look at traumatic brain injury and mental health because TBI has a major impact on the social well-being, mental health, and the ability or inability to work due to being traumatic brain injury as a result of auto accidents, serving in the military, domestic violence, gunshots. But you also need to look into with the deaf community and mental health. All these are targeted population that needs to be included with the Disparities Project. The organization that provides the Disparities Project throughout California has done a wonderful job in serving their communities with all communities
Thank you, Richard. Your
throughout
2
the
minutes are
state.
up. Please wrap up your comment.
So I strongly encourage the commission to take further additional reporting requirements relating to this report and recommendations. Thank you.
Thank you, Richard.
Next, we have Eba. Please go ahead.
Thank you so much. My name is Aba Laye. I'm the Executive Director of Whole Systems Learning, and we're one of the CRDP agencies. We focus on African American youth ages 14 to 29 who are on probation, parole, foster, or former foster. And what we found out in our evaluation is that at baseline, 57% of our participants suffer from depression, 51% from PTSD. So while they may be undiagnosed in a formal sense, we are serving people that are even above an early intervention level. We found that post-test, there was a 67% decrease in PTSD. I say this to say that we do not have this kind of access through the LA County mental health system. And although Dr. Grills told you about one program that is funded by the Department of Mental Health, that was not an open solicitation. There's never been an open solicitation for mental health disparities. In fact, when asked about it, the DMH administration said they would like to think that all of their solicitations address disparities. So there's not even any thinking to focus on Pacific population groups. The other thing is there's never been a solicitation for CDEPs. Whether that's people that formally call themselves CDEPs or not. So to take off on what Stacy was saying, the commission is going to be the only source of funding that we have in LA County to address needs that are not being addressed by the mental health care system. And as you know, for African American youth, their behavior is criminalized. When probation reported, they reported 2% of probation youth have PTSD because they don't even screen for trauma. Our young people are being criminalized when they suffer from diagnosable mental health illnesses. And there are no
Thank you,
other
Ava.
early
Your 2 minutes are up. Please wrap up your comment.
there are no other early intervention programs in LA County. Our future rests with the MHSOAC.
Thank you, Aba.
All right, next we have Emily. Please go ahead.
Thank you for these conversations. This past Monday, I was part of a webinar facilitated out of Massachusetts, and it was called 988. Is it harming more than helping? I feel like there needs to be a discussion, public discussion on 5150. Is it harming more than helping? And, you know, because I think that if people were to be suggested to 5150, where there is no trust that is built between a person, law enforcement, and the healthcare providers. And I've been looking for answers and transparency from the system, because I'm like, I would love to see the system provide a workshop on what happens in a 5150 and how is it supposed to be conducted. Who is in charge of teaching law enforcement on how they are to conduct a 5150 appropriately? Because if I look at the law and the wording of the 5150, it says that you're supposed to introduce yourself. What is your name? What is your role? And you say that you're not here to incriminate the individual. I feel like I have no one to talk to about whether and how is it that the system, because of the law, can allow for a person to be legally kidnapped and taken to the hospital by the fire department, and then the police, you know, already navigating the system in itself is very frustrating. I'm so sorry. This is some of the stress that I have to deal with as a cat rescuer of 5 cats, but you know, anyway, so I'm looking for answers, and I'm hosting a future mental health awareness event in the San Gabriel Valley in the coming months, because I want to invite LA County Department of Health Emergency Services Bureau. I want to invite the San Gabriel PD,
Thank you,
their
Emily.
mental
Your 2
health
minutes are up. If
evaluation.
you could please wrap up your comment.
The San Gabriel Valley, the San Gabriel mental health evaluation team, to show us what happens in a 5150, and does it match up with what if a person was 5150, they would see how traumatizing it is to receive psychiatric ward services. And I feel like we need to rethink the system. Is it harming or is it healing? And it was so harming and traumatizing, and to be given the financial burden of over $3,300 for being mistakenly thought of as a person who had a plan for suicide when I indeed did not. Thank you for listening.
Thank you, Emily.
Next, we have Regina. Please go ahead.
Good afternoon, commissioners. Thank you so much for giving me the opportunity to speak today. My name is Regina Mason. I'm with the Village Project in Monterey County, and we are part of CRDP Phase 2, and we have an Iminyata Saturday School for children of African ancestry in grades K through 4th grade. And so we started the venture 7 years ago. Now all of the original warriors are in middle school and some in high school. And now we have unduplicated warriors that are in that same age group. And basically, I have seen and experienced how important it is for young people of African ancestry to learn their cultural heritage and identity. And I've seen how they have had stronger mental health well-being and stigma reduction. And so I really want to appreciate the Commission for putting this report on the agenda. And I especially want to uplift Park for the incredible work that they did in telling the story. And there's so much more that I'm sure in terms of the ancillary services that many of us are doing in our various projects that haven't been uplifted yet. So we're looking forward to having even more information brought forward in terms of how people's mental health well-being is being impacted in unserved and underserved communities. And I just want to also mention that we don't want this report and its recommendations to sit on a shelf and be forgotten. This is such incredible work in terms of community-defined practices and how they work. And I also just want to pick something out of what Park mentioned, and that is in the report, and that's to recognize CDEPs as innovative, effective, community-driven
Thank you, Regina.
PEI
Your 10 minutes
approaches.
are up. If you could please wrap up your comment.
Okay, PEI approaches to reducing mental health disparities, especially in underserved, unserved, and inappropriately served communities. Thank you very much.
Thank you, Regina.
Okay, next we have Alfonso. Please go ahead.
Good afternoon, Commissioners. My name is Alfonso Silva Piontek, and I serve as the Equity Policy Manager at Safe Passages in Oakland. Our organization also participates in the CRDP Phase 2, and I want to start by extending my gratitude to the Commission for including this crucial report on the agenda, the team at Park for an awesome delivery of the evaluation and results, and I want to say that I wholeheartedly endorse the report that was shared with everyone in attendance. Safe Passages leads one of the community-defined evidence practices. It is the Law and Social Justice Life Coaching Project. This is a prevention and early intervention program that specifically targets African-American youth between the ages of 16 and 21. We aim to mitigate the impact of chronic stress and trauma linked to poverty, racism, educational disenfranchisement, and involvement in the juvenile justice system. And we are very excited to see that this program is supporting a lot of youth in the Oakland community. This program focuses on reducing mental illness, addressing trauma-related symptoms, preventing school failure and dropouts, and curbing incarceration rates among our target population. I really want to urge the Commission to integrate findings from this report into developing future rules and guidelines, as well as when they're developing RFPs or RFAs and other opportunities that could fund or support CDEPs. It is imperative to acknowledge that CDEPs are innovative and effective community-led prevention and early intervention strategies that do reduce mental health disparities among underserved communities. So thank you for your attention and consideration of these critical matters.
Thank you, Alfonso.
Next we have Steve McNally. Please go ahead.
Hello, my name's Steve McNally in Orange County on a behavioral health board. My comments are my own. I've seen this presentation in several forums and I really appreciate what they're doing. And I think for me, this is a way, my journey, and it's only a journey of one, but I know all of our journeys have many similarities. If I can build trust, I can build influence to help someone else change. And I think we need to think about our implicit biases of putting evidence-based only in RFPs so that programs get excluded, or making smaller organizations, because of a complicated procurement system, have to provide their services under larger entities and not be paid at the same levels. And, you know, I like the Cayenne years ago when Cayenne came to the table, the California Youth and Empowerment Network. They showed the ladder of peer engagement, which I've shared with many groups, where it starts off at manipulation, tokenism, consulted, co-produce, and partnership. And I think the story that was told today is probably the story of what community planning used to look like in California whenever it ended in your particular area. And I think it's really important that we have as many tools as possible that help people when they need help. And it gets complicated though if you just say, well, I want this, and you don't fix the procurement system because it won't get through. And there's many smaller organizations I know that don't have bloated overhead because they actually do the work. So if they show up to come to an event or something, I will. Thank you very much. They either can't help an individual or they can't produce revenue for their organization. And they're more apt to go after federal funding than state or certainly county funding. Thank you very much.
Thank you, Steve.
Okay, next we have Lueni, and I'm sorry if I pronounced that wrong. Please go ahead.
Thank you. Good afternoon, commissioners, and thank you for this opportunity. My name is Lueni Mosina, and I am with the Essence of Mana program based in South San Francisco. We are one of the 35 implementation pilot projects that specifically serves the Pacific Islander community under the California Reducing Disparities Project. I am speaking in support of community-defined evidence-based practices and emphasizing the importance of CDIPs. CDIPs are an innovative and effective approach to reducing mental health disparities within our unserved and underserved communities. As a person who is part of the same Pacific Islander population that I serve, I can truly say that CDIPs do work. Evaluation and data is something that is not very familiar within my culture and community. So with all the data that was collected in the park report and through CRDP, this has given us the chance to elevate our voices and uplift our programs by addressing our population's disparities, as well as promote healing through a community and cultural lens. Thank you again for including the park report on the agenda, Whawhatai Lava, and thank you for your time and consideration.
Thank you, Lueni.
Okay, last public comment, we have Laurel. Please go ahead.
Thank you very much for listening to the presentation by this team from Loyola Marymount. Sometimes in the past, as Laurel Ben Hamida from Muslim American Society Social Services Foundation and REMCO, I've been critical. And I think if you're critical, then when you're happy and you're pleased and grateful, you should just shout it out just as loud as you might when you're critical. It's wonderful that you had this presentation. I would ask you that you would, when you post the meeting online, you might put a note in that the presentation from Loyola Marymount starts at a certain point in time. It will be a little bit hard to figure out because it won't match the times on the agendas, and that each one tell one, and we get as much diffusion of this, these innovative practices through the community at all levels. That's the key at this point, other than funding, of course, is the diffusion of these innovations. Thank you.
Thank you, Laurel. All right. So again, Dr. Grills, Dr. Toledo-He, and Ms. Rodriguez, thank you for being here. At this time, we are going to move on to the next agenda item. Thank you. All right. We are a little behind schedule, so we are going to make a change in the agenda. We're going to move on or move up agenda item number 10, the substance use disorder contract authorization. So with that, I am going to, as you remember, our November 2023 commission meeting included a presentation on opportunities to allocate Mental Health and Wellness Act funds up to $20 million to support substance use disorder treatment efforts. The commission approved the allocation of $20 million in Mental Health Wellness Act funds with 20% set aside for technical assistance, evaluation, and project management through sole source contracts to support evidence-based substance use disorder treatment and to address service gaps to reaching American Society of Addiction Medicine standards, and with the commission contracting with 3 counties, 1 small, 1 medium, and 1 large, as well as other entities in the pilot program. We will hear an update from Tom Orrick, Deputy Director of Operations, who will provide an overview of proposed contracts to implement this project. I'd like to first welcome Commissioner Danovich to provide some context. Please, Commissioner, the floor is yours.
Thank you, Commissioner. Thank you for having me back on this topic. So by way of background, As you all know, the Commission had identified substance use disorder, addiction, as a priority area for Mental Health Wellness Act funding. In September of last year, the Commission heard from a panel of experts on the barriers. You can advance to that slide, thank you. On the barriers to evidence-based substance use disorder treatment. There are so many needs in the space of substance use disorders, and so many populations that are in need across so many different levels of care. Schools, the community, hospitals, the carceral system. There's just a million things to do. Our goal was to, with a limited amount of funds, to choose something that could be impactful, that would be feasible, that was scalable and sustainable. So we wanted to use a little bit of funds to get something going, and that really informed what we selected to do, how we try to thread a needle within the million really compelling opportunities that exist within the substance use space. And we also recognized that there might be several of those, but we had to just choose one because we wanted to do it and wanted to, you know, put the ball in motion, get into action. So in November, we presented a proposal to expand access to integrated medical and addiction treatment. And this was approved tentatively by the Commission. The Commission wanted additional information about some elements of what we had proposed, including particularly why we had arrived at sole source contracting and had asked us to develop a contracting strategy that could allow other entities to participate should they want to and have the capacity to do so. So this, if you could, oh great. This slide summarizes the funding strategy. The initiative that we chose is described here as, it's kind of complicated to ask, a medication-assisted treatment, which is MAT, prescriber cost-sharing program. This particular initiative was about giving support to residential treatment programs, to onboard physicians who could provide evidence-based treatment for certain substance use disorders. That's the leading edge of what is behind this initiative. It's not just about using medications to treat addiction. There's not single medication answers for all of addiction. But the real purpose of these initiatives is to integrate medical services in addiction treatment settings. Those medical services may be a medication for addiction treatment, but it also may be a medication treatment for depression or for anxiety. It's also making sure that people have medical evaluations. It's part of this integrating of systems to improve care and outcomes for patients and not making them get care for substance use in one space and then another space for their mental health problems and another space for their medical problems. So it sounds narrow when you hear the focus of this, which is including people with the capacity to prescribe certain medicines for opioid addiction, but it's really the leading edge of a broader strategy to integrate these systems. That's what this next bullet, medical services in residential facilities. Actually, residential drug treatment facilities, because of outdated policy, aren't allowed to provide what's called IMS, incidental medical services. And they have to file for waivers in order to be able to deliver medical services to their clients in residential. This is a relic of an outmoded system that viewed these conditions as fundamentally separate health systems, separate health issues rather than connected health issues, which they are. And then another intervention here is just using telehealth to improve access to these medical services for people that can't access them in residential facilities or other facilities. So that was about 3/4 of the funds, a little more than that, 16 million out of the 20 million, and then the other 4 million was for technical assistance, for research and evaluation, for project coordination of this initiative. You can advance to the next slide. So why is this important? I guess I've been laying that in as I've been teeing this up. This really fundamentally promotes the integration of medical and mental health care services. And again, I always frame substance use disorder as a mental health condition, which they are. This aligns with the state's goal to bring substance use disorder services and mental health treatment together in a holistic approach. It improves access to evidence-based substance use disorder services, promotes collaboration and shared learning, and it achieves this thing, we hope, this is what we'll see, of the scalable and sustainable, because the mechanisms to support these services already exist. But the challenge is that there's a huge threshold challenge for a program that has not been offering these services, has not been working with physicians, has not been storing medicines, has not been working with nurses to develop the capacity to do so and to learn how to be able to build the appropriate entities to be able to stand up those services. So what's needed is to kind of fund the front end, the sweat and energy and work it takes to recruit and find people and do change management and do things a little bit differently until things are in process, and then the tools are already in place to be able to sustain these activities. And this is why we think that this could be something that creates a result that's more than the sum of its parts. So I think this is my tee up to Tom to talk about how we responded to the feedback that we received, but I could chime in anywhere that we want. Tom, are you with us?
Yes, great. I hope you can hear me. Thank you, Commissioner Danovich. Yeah, I wanted to just share some of the feedback that we received in November was related to sole source contracting. And so we wanted to make sure that we address that. But I want to then share with you some of what the commission staff has done since November, between November and today. So commission staff heard feedback, this feedback. We can go to slide 6 now. To address the feedback received, thank you. To address the feedback that we received regarding sole source contracting, the first thing we did was to craft a letter of request for letters of interest. And we sent it out through our listserv and through partner agencies to allow clinics, CBOs, and county behavioral health departments to indicate their interest, their level of interest in participating in the pilot project. So, and then while we were waiting for those responses to come in, we then met with subject matter experts who we feel can meet our needs in the area of technical assistance, research and evaluation, and project coordination. Our goal in the meetings with them was to assess for their interest and also for their capacity to participate successfully in the project and to help us bring the lasting change that Commissioner Danovich spoke of, and also to help us as we're trying to create greater access to treatments that we know can be life-changing. As we saw in LA, a lot of us came from the site visit we had there with the sense that, it really shouldn't be so difficult to access medications to assist people in their recovery efforts. So for the provider piece, in terms of the letters of interest, we received 22 letters of interest from a variety of organizations, both county behavioral health departments and community-based clinics and organizations. The commission staff evaluated the letters using a scoring rubric based on the 5 questions that we posed in the request for letters. We can go to the next slide. This slide provides the questions we asked respondents to address in their letter of interest. We asked them to indicate their level of interest and their ability to receive funds, to describe the populations they would serve, with an emphasis on historically underserved populations. This was part of the feedback we received from the commission in November. We asked them to discuss opportunities for cost sharing, fiscal sustainability after the pilot ended, and to detail the feasibility of then partnering with medical personnel. We also asked them to share the impact or benefit that they anticipated would happen as a result of the program. We can go to the next slide. So with the completion of the evaluation of letters of interest and after discussions with the selected subject matter experts, we're recommending that the commission authorize funding to the following entities to participate in the SED program, which will expand access to medication-assisted treatment. The recommended providers include LA County Department of Public Health, Bureau of Substance Use Prevention Control as the large county. The medium-sized county selection is Marin County Department of Health and Human Services, and the small county selection is Nevada County Behavioral Health. We also recommend authorization to contract with the California Institute for Behavioral Health Solutions to provide technical assistance, the UCLA Integrated Substance Use Programs to conduct the evaluation of outcomes, and Jet and Associates to assist the commission with project coordination. We've provided a one-page summary of the letters of interest received by the provider counties, as well as a summary of CIBHS, UCLA, and Jet and Associates. I think that was underneath your packets as you came in today and was sent out to commissioners. We can go to the next slide. So the proposed motion is that the commission approves their recommendation for expenditure of Mental Health Wellness Act funds in the amount of $20 million to address SUD, which includes a total of $16 million to the 3 selected applicants identified in the outline, and $4 million to conduct technical assistance, pilot evaluation, and program research, and project coordination. And with that, we're happy to take any questions.
Commissioner Chambers, please. I'm sorry, I didn't see you, Commissioner Carnaval.
Thank you, and you can remind me if I'm getting this wrong. Was there a reason why, and we probably talked about this before, and maybe because these organizations contract out with CBOs, that none of the individuals from the 16 CBOs were contracted unless that's the institute, the California Institute? And you can remind me if we made a decision to not, because the other organizations would guarantee to contract out with other community-based organizations. I know these people are doing a lot of great work, they just have a significant part of the field. So maybe because they are the experts and they'll be able to provide the TA, but just wanted to ask. And maybe, like I said, we answered it before.
I wanted to clarify, are you referring to the pilot counties or the contractors?
Yeah, I mean, yeah, so I guess the people that were on the, yeah. So, yeah, the recommended pilot participants and the contractors.
Yeah, so for the pilot participants, we opened that up to all organizations, county behavioral health departments, as well as clinics and community-based organizations. In the large county area, as you can see on the summary, we received 14 letters. 1 was from a county, but 13 were community-based organizations. And then for medium, we received 5 letters, 2 from counties and 3 CBOs. And small counties, they were both from counties. In terms of the organizations we've spoken with, that I really, which I think is really a great collection of people who have vast knowledge and experience, subject matter expertise in this area. We spoke with them on recommendations to CIBHS, who has been doing a lot of this work for SUD and providing technical assistance across the state, working closely with the Department of Healthcare Services as well for past efforts. And then also the UCLA group, who has conducted research and evaluation on SUD programs specifically. And then for Jet and Associates, Kathy Jet is a known expert in this field. She was the director of the Department of Alcohol and Drug Programs and Undersecretary of Rehabilitation at CDCR. And we feel like this team together with these counties will be an excellent group to really provide us a lot of information about how we can increase access to better treatment for people who are seeking recovery from SUD.
So, yes, I'm familiar with all these organizations and their like world-class service. So are you saying that this technical assistance, the community's input would be like funneled through the California Institute for Behavioral Health Solutions? And that's how we'll get the technical assistance and feedback relative to community-based providers that are doing this work, or through SAPC that mainly contracts with, I guess they contract out all their services. So I'm just trying to figure out like, how are we gonna get the technical assistance from the folks on the direct ground, the CBOs that are working with these psychiatrists and, I don't know. Is that like a question that's, maybe it's just left field?
It might be something that, it might be the next step in this process. The way I'm hoping this works out is that if we get authorization to move forward in this direction, we would then meet with and have our project coordinator meet with, along with the commission, all the different entities involved in this, with the counties and the technical assistance and research team. And we'd start to put together a plan for how we're going to conduct all these different areas of the pilot. So we want to make sure to get their input as well. And I think those are probably questions to be worked out as we put the plan together.
Thank you, Tom. Commissioner Rolette, please.
I'm going to try to assist, and in this case, I'll say staff, in answering the question that my fellow commissioners answered, as I appreciate the question. And let me just also say that my appreciation of questions isn't always accurate. But as I appreciate this question, the California Institute of Behavioral Health Solutions, I'm familiar with the organization and its CEO because I was the former board chair of the organization. So that also speaks to why I'm going to abstain from voting on this. But if I could vote, I would vote favorably, because as a CBO who was the board chair, one of the things that was clearly an objective of the organization is to make sure that not only were family members and consumers represented on the board, but also that there were strategies incorporated in their work that included the solicitation, not just of their perspective, but an involvement in the work. And in the work, meaning contracting with those organizations or entities that really do that work to ensure that the perspective was inculcated in the final product, and that the outcome was reflective of what they believed would work for the community that they represented. A long-winded way of saying, I think they do what you are asking. I do believe that. And I've seen it firsthand by way of experience. I have an advantage that staff don't have, because I was there and was a volunteer for 8 years.
Thank you, Commissioner Rolette. Commissioner Carnevale, please.
Thank you, Madam Chair. A comment and a question. First of all, I'm very much in favor of this. I was stunned when I first joined the commission and learned that SUD is not necessarily considered part of mental health. From my neuroscience viewpoint, these are all conditions that come out of the brain. I don't know why we would treat them differently. I don't know why we wouldn't also treat them holistically, because you can't treat some circuits in the brain and not others. You've got to treat the whole brain. We only have one brain. It'd be like treating the left ventricle chamber of the heart or something. So this makes complete sense to me. My question is, this came out of, among other things, our site visit to Skid Row, which I thought was an amazing day. And then we had that robust conversation the next day. And part of what came out of it for me and through my business brain is that there's what I call a supply chain problem where there's a misalignment of incentives and systems between federal and state and local that creates all of this inefficiency and problems in the system. I'm just wondering, in the course of this contract, I'm hoping, and I guess a question and a hope, are we expecting these contracts to highlight those issues and maybe try to get them resolved in the course of also delivering services?
Tom, I can take a first crack at that.
Yeah, great.
I'm in, but it's a great question, and I think we all felt that particularly after the Skid Row visit, because the need there is so dire. There is some element of that telehealth services enable delivering services to a much broader array of patients, but we made a decision to really go upstream of Skid Row, because our notion is like the specialty treatment system is one of the mechanisms to help people achieve recovery before, they have suffered enough that they have lost their housing and that they've ended up on Skid Row. And the services in Skid Row are essential, they're necessary, they're reducing harms and hopefully giving people routes out. The main intervention at Skid Row that's necessary is housing first, and then adding everything to that. So we could put all these resources into Skid Row, and I think not necessarily move the line as much as we would like. And we think that there's a lever here in the specialty treatment system to strengthen it, so that we can both be getting, people when they are started on treatment in Skid Row need to be able to enroll in residential programs often to continue to get better, so they have that capacity to do that. And for people that, whose lives are struggling but not so unstable that they're on the street, hope we can get them, the treatment they need before they come to that. So that's why investing in the specialty treatment space seemed to be such an important part of the system to bolster.
Got it. Thanks, Commissioner Danovich.
I guess I would add too that, our hope, and as I've been talking with the UCLA, is that they could produce a white paper which outlines some of the barriers to access and some of the system failures that we see in the state. That's a large piece that I would recommend that we have as part of that contract with UCLA, so that we have ongoing information from them based on what they've learned from this pilot, and also what they've learned from the other participants and their experience in trying to operate programs throughout the state for many years.
Commissioner Mitchell, then Vice Chair Alvarez, please.
Every time Skid Row comes up, I always go into my blue. If you're familiar with real colors, so I'm a blue. I'm a really emotional person who functions from the heart. But with all due respect, Dr. Danovich, when you said upstream Skid Row, it just made me think upstream was years ago. And I know we can't do anything about the past, but if we're going upstream with Skid Row, it's like, it's such a forgotten community. So that's my blue statement. I'm just, for staff or those who worked on the selection, and I don't know if this is a fair question, but I get saddened when I think of Alameda County and San Francisco. So because we seem to do so much for Los Angeles. And again, I don't know if that's a fair comment, but we do. So did our other counties that are considered large, did they even apply? Because when I think of what's happened in San Francisco, our beautiful city with, tourists from all over the world, no different than Los Angeles, were they even considered? Did they apply? Again, I don't know if that's a fair question, but I am asking because I'm just curious, because they have the need as well for a project such as this. San Francisco, Alameda, and again, no disrespect to Los Angeles, but we do so much for Los Angeles. I'm just curious. I don't even know if the question can be answered.
Well, I think that, it's an interesting question just in general. Does Los Angeles get more than their population basis? It's 25% of the population of the state. It's a huge county. And that's something we should answer in general. I think that we initially went in this and we identified, since this is a very specialized project, the counties with the interest, capacity, and an ability to do this on short notice, which required both, counties and technical assistance partners that had the readiness to do this, but needed some resource to be able to do it. And then after getting the feedback from the commission that there was a desire to be more inclusive, went through this RFP process so that anybody could apply and show and express their interest. And I think Tom spoke to that, so he can, I think, answer your question more specifically.
Yeah,
But-
I'm sorry that I didn't, we typically wouldn't put the counties in there that applied, but neither applied, those that you mentioned. And so we did our best to put that out there and make counties aware of it.
I have a comment, and I'll be quick because I know we're running short on time. So one is an observation. Like, as I heard you talking, Commissioner Danovich, I was like, we don't already do that? Like, have physicians on site to create this holistic continuum of services? And I want to have us reflect on what that stems from as far as a baked in racism in our system, right? That considered substance use as individual behavior, right? Versus something that is part of, baked into our systems as people and our health and our experiences. So I really want to just call attention to that this was more like a no-brainer to me, and I was a little bit shocked that we don't already do this. That being said, I have a curiosity of what is the future of something like this, to ensure that it is not just these programs, but that others have these types of holistic opportunities for wherever you're seeking substance use treatment, and if telehealth is part of that solution. Because telehealth opens doors to additional providers that don't have to be on site in ways that can address some of the shortages or some of the pipeline issues and things to that effect. So that's a curiosity that I would love.
Yeah,
just your
well,
thoughts on.
the past is separation of services.
Yeah.
And actually, residential program, as I mentioned, we're not allowed to provide medical services. The future is integrated services and on-site services and telehealth. Both of those are ways of bringing those services to be able to integrate it. The mechanisms to do that are now in place in terms of payment mechanisms and, policy changes that are still in order. We still need to get a law written to change the IMS exclusion so that programs don't need to have to proactively apply for a waiver to offer these medical services. But those things are in place. What this is trying to do is get over the activation energy, because it does take change management for programs that have been offering services for a long time with a certain model of care without medical services, perhaps with certain ideas about how that you don't need medical services. There's a lot of change that has to take place, both to logistically support the process, get through the workforce challenges, actually hire people, develop all the internal abilities to manage medical services that come up there. That's a whole, keep records on all. So there's that component, of it, and then ultimately have those services appropriately be billed to health plans and payers and generate revenues that sustain them. So we do think it's sustainable. We do think it's scalable. We do think that doing this well in any, single county, whichever it is, whoever's ready to do it, creates momentum for others to be able to do it, because there start to be examples. And that's what we want this to turn into, an avalanche of, all of the residential programs across the state offering these services. So for me, it's like, I don't really care which county it is. I happen to be in LA County, so was convenient to know and figure out who was doing this stuff there, but it could be any county. The point is to build momentum and just to, make stuff happen, and to do it quickly, work with people that are ready to do it, so we don't spend another 1 to 2 years just kind of generating the will to start.
Commissioner Brown.
This question could be either Tom or Commissioner Danovich, I guess, but the report clearly breaks down the 20 million, that 16 will go to the 3 counties and 4 will go to the evaluation services. What is the breakdown on the funding for the large, the medium, and the small county, and how is that determined?
Yeah, we have thoughts about that. We'd like to consult if, the commission would be okay with this. We'd like to consult with our contractors on this question. We want to ensure that this is an equitable distribution of, funds to small, medium, and large. And we also want to make sure that the funds provided can be spent. And so this is largely a medical personnel expansion grant, really. So we want to get estimates on how many providers can reasonably be engaged in the pilot. Our initial thought was to distribute 13 million to Los Angeles, 2 million to Marin, medium-sized county, and 1 million to Nevada, the small.
Was that based on any population?
Yeah, we
breakdown, or
based
how
that
was
on
it?
population as best we could. It's difficult though, because LA is so much larger than the other 2 counties, that it really doesn't pencil out completely to do it by percentages. But this is why I think we would, love some flexibility to work with them and work with the contractors to determine the best way to allocate those funds. But like I said, our initial recommendation, would be 13, 2, and 1.
All right, we are going to, go ahead.
Just one last comment. I don't mean to beat a dead horse to death, but I'm just curious, in the future, when counties don't reach out, can we reach in? Because it could be capacity. So I'm sure, there's a reason why some counties apply and some don't. We've heard that before. But just for purposes of a knock on the door to say, hey, this funding is available. Do you guys have capacity? Do you want to apply for it? I don't know what staff's ability is to do that, but I think some counties miss opportunities because of capacity issues. They just don't know. And if you're using listserv or, whatever those communication vehicles are to let counties know what's available, and it does. It just breaks my heart that some counties that really need the support, I know we can't save the world, but they just don't seem to be at the table.
I think, I make one comment on that.
Yeah.
I agree. I think that when we talked about this at the outset, if we spread out these funds, if we had the ability to, across all our counties, we wouldn't have enough in any county to have any impact at all. So assuming everybody was interested. Well, we had an amount that was both a big amount, 20 million, and a small amount spread across over our big state and all our counties. So then how do you choose whom and what? Our strategy was to try to have enough to have an impact where we are and to build that momentum, because this clearly needs to be rolled out across the board, to other, to all counties and all the different areas within counties. But that was the trade-off that we struggled with, is, taking this and trying to have a specific impact versus having it be spread out and diffuse and touching a lot of areas, but maybe not having the impact that we hope for.
Thank you, Commissioner Yanovich. And there's an immediacy. If they're ready to go, and they're ready to go now. We have people, we're in the middle of a crisis, especially when we're talking about substance use disorders. So while I appreciate that and absolutely agree, I think there's a time and place when we reach out to those counties. But they're ready to go now. And with people dying in a matter of minutes and hours in our state with substance use disorders, we have to get this rolling now. So appreciate the work that the team has done, the leadership that Commissioner Yanovich has done on this as well. And so I would like to move on to public comment, so then we can go to the motion, and we still have another item that we need to also vote on. So at this time, members of the public may request to make a public comment on agenda item 10, on this agenda item by clicking raise hand button on your computer or the app, or if calling in by phone, push *9. Are there any public comments? Please raise your hand now, as the queue will be closing. So Kendra, do we have public comments in the room first?
Nope.
Thank you. And any public comments online?
I don't see any online.
Thank you. So I would entertain a motion that the commission approves the recommendations for expenditure of Mental Health Wellness Act funds in the amount of $20 million to address SUD, which includes a total of $16 million to the 3 selected counties identified in the presentation and $4 million to conduct technical assistance, pilot evaluation and program research, and project coordination.
So moved.
Thank you, Commissioner Carnevale. Do I have a second?
Second. Commissioner Bunch.
We have a second by Commissioner Bunch. We can make any other questions or comments. See none in the room nor online. I would ask that Maureen please take the vote.
All right. Commissioner Bontrager. Commissioner Brown.
Aye.
Commissioner Bunch.
Aye.
Commissioner Carnevale.
Aye.
Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen. Commissioner Chen. Okay. Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell.
Approve.
Commissioner Robinson.
Approve.
Commissioner Rolette.
Abstain.
Vice Chair Alvarez.
Aye.
Chair Madrigal Weiss.
Approve.
The motion carries.
Excellent. Thank you. All right, we are going to move on to agenda item 11. The commission will hear a presentation on the governor's 2024 proposed motion as it relates to behavioral health. Consider expenditures for the 2024-2025 budget and will consider legislative priorities for 2024. We are going to hear from Norma Pate, Deputy Director, Administrative Services and Performance Management, and Kendra Zoller, Legislative Deputy Director. Commissioners will vote on the governor's proposed budget presented by Norma and the legislative presentation on by Kendra. It is for, we will not vote, wait, I'm sorry. Will we vote? We will vote.
Yes, there will be a vote.
Thank you. Please go ahead.
The governor's proposed budget piece. It's the materials are in your packets. There's oh, sorry. Can you hear me? All right, sorry. I'm going to go ahead and skip over the governor's proposed budget piece because the materials are in your packet. We don't know a lot at this point other than what's in the packets today, and we'll start budget hearings and we'll have more of an overview of the governor's proposed budget in May for you. Just make sure we stay on time for this meeting. If you can go ahead and, Cody, and skip to the slide with the, where it says key opportunities. I'm going to turn to Toby for this one. This is, we reappropriated 1.6 million of our early psychosis funds that we received in prior year's budget. Those funds are now available, and Toby's been working on a proposal for early psychosis, and I was going to have him give an update to the commission.
Thank you, Norma. So several years ago, we received funding from the legislature to focus on early psychosis intervention. Consistent with my comments earlier around the strategic plan in response to Commissioner Mitchell about how we're actually translating this work into impacting the lives of individuals, I mentioned the gap in access to care for people who are in the early stages of psychosis, that research suggests 5 to 10% of people are able to access effective care within the initial stage of their psychosis diagnosis, but the balance do not. We have been working very successfully with the administration to better understand that opportunity and to put in place strategies to strengthen the ways in which we respond to people who have psychosis. Next month, we will be in Napa. We'll be participating in a site visit to the state hospital with a focus on people who have been identified as incompetent to stand trial. They've been directed to Napa State Hospital for competency restoration as part of their criminal charges. And the research coming out of that department shows that the vast majority are struggling with psychosis, and have not received consistent community-based care. The commission authorized staff to distribute the funds that we had received for grants to increase effective practices and set aside a portion that we ended up not spending, the $1.65 million, for research and outreach. At that time, we did not have confidence in how we could use those dollars. In the interim, we've been working with a number of partners across California, across the country, and within the Health and Human Services Agency, and are bringing to you a request to use those funds to bring in a contractor who can facilitate a process to understand the landscape in terms of accessing effective early psychosis interventions, understanding the impact of unmet needs, particularly on public sector budgets, so that and understanding the barriers to scaling access to care, so that we can put together a game plan to move from where we are today, serving 5 to 10% at best, to serving 100% of Californians within a very aggressive time frame. The United Kingdom and other nations have established clear goals that all residents will receive effective intervention within 2 weeks of the onset, and they monitor that. We do not have a comparable goal, and so the ask of a research partner, because we do not have the capacity in-house, is to help us put together the key components of a strategy that would allow us to get to that goal. Not to implement the strategy, but to design it. We've talked with the Health and Human Services Agency. They're excited about this opportunity, and they want to do this with us. And so, so on the slide, the ask is $1.65 million to develop this strategic plan for early psychosis intervention. We would focus on financing, because if we can't pay for it, we can't scale it. The fiscal impact, so that we can do the ROI, the cost-benefit analysis, and help make the case for the investment, technical assistance, research evaluation, workforce, certainly the public narrative that focuses around care-seeking behavior, but also understanding what it takes to get it right. And so in the context of the Reducing Disparities presentation that you just heard, really understanding what that would mean to achieve universal coverage. This work is being linked to a national initiative. The Commission has been invited to partner with 4 or 5 national organizations that are part of a similar conversation that is just getting off the ground. And then we will work closely with the California Health and Human Services Agency to identify that research partner, because success on that strategic plan will require support from the administration around those policy, fiscal, and practice issues that we've mentioned. So Norma wants to present the broader budget. We can vote on this item as a standalone item if you would like, but we also wanted to put it in the context of the broader budget. Typically this time of the year, we give you an overview of where we are in our expenditures. We pull out specific areas of authorization if necessary. This is the only authorization pull out that we have in front of us at the time. Happy to answer any questions. Thank you.
Cody, if you want to go to the budget chart slide, thank you. This is an update. There's 2 parts to this presentation. One is the overview of the governor's proposed budget for the new year, and then an update on our mid-year expenditures. This is the chart and the dollars that the commission adopted in August this year or last year, and there hasn't been any changes other than the ask today for the early psychosis funds. But just to kind of give you an idea of that this is still where we are. We're still on track with a proposed spending that we provided to you in August. So I don't have an ask for you today other than the early psychosis ask. And then I also wanted to just point out that the Department of Finance issued a budget letter directing departments to reduce current year spending. And the commission, we're working with the Department of Finance to support that effort. And at this point, we don't envision any changes in our strategy or primary initiatives, but we are exploring with the governor's team how we can best support cost reductions this fiscal year. We'll share more as the budget process moves forward. But, and then also wanted to give you an update on our competitive bids that are underway right now. The CYBHI Round 5 Early Intervention, all applications have been scored and sent to Department of Healthcare Services for their review. And as far as our advocacy dollars, the $5.4 million that we receive ongoing for advocacy, their family and clients and consumers, the applications have been scored, and so those are moving along. Parent and caregivers, all those applications have been scored, and the intent to award was announced, and a contract is being drafted. United Parents was the winner of that contract. And then the LGBTQ+, all applications have been scored and are underway and moving forward. And client and family consumers and diverse racial and ethnic communities have been scored and are under review. Veterans, same, all applications have been scored and under review. So we should have announcements for you next month for those. And then some of our other procurements that are pending are, you heard today on the MHWA SUD request today, and then the MHSSA will holding over until next month. And then the K through 12 advocacy will present it to the commission also in February. And Cody, you want to go ahead and move to the motion slide? Okay, and then happy to answer any questions you might have.
Any questions? Comments? Okay, I see none here in the room. Any online? Kendra?
No public comments online. Then we have two in the room here. And first is Stacy Hiramoto.
Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. We just asked that in the RFA or in the new redirect for the early psychosis, that the proposal or proposers include strategies that will address reducing disparities for BIPOC and LGBTQ communities, individuals and communities. I have spoken with people at the county level because this is a while ago, but I wanted to understand why communities of color and others were not as interested in the early psychosis programs of the MHSA, or why, what was the deal with them? And they told me that it was very clinical, although yes, studies show that it is effective, it is very hard to implement because you need clinicians and licensed people, and I think you also need a doctor, right? And so to have people of color, people non-English speaking, people from the LGBTQ community, they find it hard to just, have them want to come into these programs. So I really think there should be some attention paid in this redirect to how they're going to address that. Thank you.
Thank you, Stacy.
Next up, we have Katara Tamplin.
Good afternoon, Commissioners. And I just want to apologize because this is more general public comment, because I know this is the last item. I wanted to, thank you all.